Good morning, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Virtual Learning Series on Preeclampsia, Series 3 and Episode 1, organized by the Society for Maternal Fetal Medicine, India. So it's my privilege to introduce the coordinator of today's webinar, Dr. Akshita Sheth ma'am. Ma'am is the consultant at Manimal Hospitals, Malleshwaram, Bengaluru, and ma'am is currently working with SMFMI. I welcome you, ma'am. And it's my honor to introduce the coordinator of today's webinar, Dr. Anu Joseph, ma'am. Ma'am is the medical director and senior consultant at Trinity Healthcare Clinic, and also founder member and executive committee member of Society of Maternal Fetal Medicine, India. I welcome you, ma'am, and I hand over the session to Akshita, ma'am.
Good morning, everyone, to our third series and the first episode here, where we are dealing with the cardiovascular diseases and its association with preeclampsia. Our first session will be by our own president, Professor Dr. Prakash Mehta. So will give us an introduction to SMFMI. He will also introduce PENI to all of you, and he will welcome all of us today. Over to you, sir.
Thank you. Okay, good morning, everybody. Both the faculty who are present on this particular platform, as well as our delegates from all across India and outside, and of course our future YouTube viewers who will, when this program is put on the YouTube. So I welcome you all to this third series of our VLSP. This is the first episode of the third series. Every year we are having this VLSP series covering a particular aspect of preeclampsia. And today's aspect would be on cardiovascular present and future cardiovascular disorders in a patient with preeclampsia. Lao Tzu has famously said that the journey of 1,000 miles begins with a single step. This is exactly what happened to the Society for Maternal Fetal Medicine. We started in a very small way as the MFM initiative. It was a goal set and pursued by a group of like-minded clinicians from India who practice maternal fetal medicine. At that particular time, we were 9 members, and which was the minimum we needed for registration of our society. And from that day onwards, today we have grown to almost 4 digits in membership. Now, the MFM initiative soon changed into SMFMI, and it was officially registered on the 14th of March 2017. So we are less than a decade young right now. And of course, we had a support from both India as well as abroad so that we could carry on our programs very well. And the global launch of SMFMI occurred during the World Obstetric Medicine Conference, which was held in South Africa. The basic motto of our society has always been what Swami Vivekananda said: arise, awake, and stop not until the goal is reached. So this is the philosophy we have been following, and I'm very happy to say that all my young members who are on the committee and who are working for the society have really followed this motto to the last word. We basically believe in research, audit, and guidelines. And of course, we have a lot of academic meets, which we are very happy to state, are transmitted across globally. And of course, being on the YouTube, and we are also tagged on to the International Society for Study of Hypertension website, where we get many hits for these particular programs. And our main aim is to collaborate with other academic bodies, individuals, and clinicians, as well as researchers, so that the patient care improves. We have many meetings, interactive sessions, which are, I told you, already transmitted across India and abroad. We have meetings on preeclampsia, preterm labor, viral infections, and many more topics in high-risk pregnancy. We started like the small sapling, and now hopefully we have become a banyan tree with roots spread across everywhere. We had our first branch coming up, Mysore Society for Maternal Fetal Medicine India, and we have now members, as I told you, from all over India. PENI, the Preeclampsia Education Nation of India, has been our flagship project. And of course, Dr. Reti will be speaking a little more when she goes into this particular topic later. Okay, we started basically as an online program. This happened during the COVID times. And then we started going on site. We have concentrated on nurses, we have concentrated on undergraduate students, we have concentrated on the alternative streams of medicine like homeopathy and Ayurveda, so that everybody who is practicing medicine in whatever field they may be are aware of what happens. One of our good meetings we had was in Tirunelveli and then in the south and to Gorakhpur in the north. We have gone everywhere trying to ensure that preeclampsia patients get good care. And now, of course, we are going to have many more international collaborations, which will be told to you later. Once a person gets certified by the Preeclampsia Education of the Nation program, in order to ensure that they keep themselves updated, we came up with this program of VLSPE, which is held at various times so that these two doctors who have been certified for preeclampsia continue to learn and continue to update their knowledge. The feedback for our programs have been excellent, and you can see that most of the time the feedbacks are very good and which encourages us to continue the program as we are doing. One of our important things that we held was the iShip World Congress. We named it as Prajna, the knowledge. And the making of the Congress was a big deal. We were hardly about 4-year-old society. We were all young, financially not sound. Yet, in spite of that, we carried out this program. And even today, whenever an iShip Congress is held anywhere else in the world, the recent Congress was held in Chicago, people were still talking about our Congress and said this was one of the best Congress they have attended. So the Congress itself saw who's who in the field of hypertension in pregnancy, and I think it was a very, very fruitful conference. Then we had our annual conference, which we hold every year. Once, apart from the regular programs, we have a 1-day or a 2-day annual conference where people from all across India come and attend this conference. One of the landmarks in our society's thing was the book on preeclampsia. It was called as an Enigma Unraveled. It was a global perspective. We had international authors contributing to it. We had international editors coming as a part of our program. And the book was actually released initially in South Africa and later on in Bangalore when the book was fully published. We had our first oration, the Mayabai Kantilal Mehta oration by Dr. Kenneth Shen from Harvard. And our next annual day program is probably coming up in July. We'll keep you all informed. Please do join us for that annual program. The next important flagship project that we are coming out is called as Suraksha. Suraksha means protection. And we want to use this program to ensure that our women out there, maybe educated, maybe uneducated, maybe literate, illiterate, rich, poor, whatever category they belong to, get good kind of support and good kind of knowledge. So we are also having many community service partners coming up with this program. One of them is the Rotary International, and the other one is the Family Planning Association of India. And we will be having a program on the Preeclampsia Day, that is on May 22nd, when the Suraksha program will be unraveled. Also, I have to point out that we all know that May is the month of preeclampsia, and this particular topic of VLSPE was chosen today, keeping in mind the preeclampsia month. We also have what is called as the SIG, or the Special Interest Group, meant for catalyzing innovation and focused collaboration, and it explores distinct academic and research domains, including implementation and translational medicine. Okay, we are hoping that by these programs, we generate impactful outcomes that improve the health of pregnant women and their unborn babies. We have, of course, our flagship PENI program through the hypertensive disorders of pregnancy, of which is led by Dr. Revati Rajan. Then we have the preterm birth by Dr. Sunita Mahesh. We have labor and delivery by Dr. Suchita Mundle, nutrition by Dr. Srimati Raman, and the Suraksha itself, which is led by Aishwarya Karthik, and then we have the endocrine disorders led by Dr. Sushma Vinde. Our policy has always been, as we say in Sanskrit, yata ekena chakrena na ratasya gati bharvet. Evam purushakaranam vina devam na siddhyati. Just like a chariot cannot move on one wheel, we cannot attain our destiny without hard work. So this has been the policy, and anybody out there who are listening to this topic, who wants to contribute something to the society, to the community, you're most welcome to contact us at the office address, which will be, of course, flashed later, and email as well as the WhatsApp number. And you please join us, and we will be very happy to have your cooperation and collaboration so that we can go forward. Thank you very much for a patient hearing.
Thank you very much, sir.
Have I stopped sharing?
Thank you very much, sir, for that introduction on SMFMI and what are the activities that all of us are doing. And now we move on to our next session. The next session is a talk. Saiti, the next slide, please. Next slide. Yes, thank you. The next session is a talk by Professor Annie Catherine Staff. Professor will be talking on long-term cardiovascular outcomes in women with PE. Madam is a professor in OBGYN at University of Oslo and the head of research at Oslo University Hospital. Ma'am is the vice president at ISHIP. She's an international leader in preeclampsia and placental biology, and she directs a major multidisciplinary research center in mentoring more than 30 PhD level researchers. Madam's currently the head of research at RESCOG, that is Research Center for OBGYN, and she has multiple ongoing projects like Oslo Pregnancy Biobank, Match, Fetch, PATH, and HAPPY, and she has several publications on hypertensive disorders of pregnancy and GDM, and also on placental biology. We welcome Professor Annie Catherine Staff on her talk. I request all delegates to kindly put up their questions on the chat box, and along with the questions, kindly please type in your email ID so that we can respond personally to them. Thank you. Over to the talk, please.
Hello, everyone. My name is Anne Catherine Staff, or Annetine Staff, and I am the Vice President of the ISSHP. I'd like to start by thanking Dr. Prakash and Dr. Revati for inviting me to give this talk for the Preeclampsia Education of the Nation in India. And I have no conflicts of interest to disclaim, except that I really like India, like here from Taj Mahal in my April visit. I'm going to talk about the long-term cardiovascular outcomes of women with a history of preeclampsia or any form of hypertensive disorders of pregnancy. Now, the first reports were not population-based. They were case reports from the US and UK stating that perhaps women who had had eclampsia or preeclampsia had higher risk to die of earlier and also have more risk of diabetes and also more risk of myocardial infarction specifically. Later, we had more population-based studies, and this is one of the first, coming from Norway in 2001. And here on the x-axis, you can see how years from delivery after birth, with the lowest survival rate of those who had a preterm preeclampsia, high survival rate for those who had a term preeclampsia, whereas those with a preeclampsia delivery or a delivery at term, they had the lowest risk of dying, and most of these deaths were cardiovascular. And this study also looked at the fathers, but there were no association to long-term risk of death of fathers after preeclampsia. Now later on, there were many more population-based studies that showed exactly the same, from Scotland, from Denmark, from United Kingdom, and showing that there was increased risk of hypertension and stroke and ischemic heart disease. And the risk was about twofold after late onset preeclampsia or gestational hypertension, whereas it was much higher, up to 8 to 10, if one had a more severe preeclampsia, such as early onset preeclampsia with a delivery before week 37 and a birth of a small and growth restricted baby, and also if one had repeated preeclampsia. Now, so we call this a dose response. The more severe the hypertensive disease of pregnancy, the more likely the woman is to have an early cardiovascular event and death. So these findings have been replicated several times, also in more contemporary populations, such as this one from the UK from 2019. Now, it's not only atherosclerotic diseases that are associated with having had preeclampsia or hypertensive disorders of pregnancy. Also, heart failure is increased, as well as aortic stenosis and mitral regurgitation. And even small vessel disease, there's an increased risk for that after having had preeclampsia. So, in summary, there is from 2 to 8-fold increased risk for early onset of ischemic heart disease, hypertension and stroke after preeclampsia. But also there's a doubling of the risk of having type 2 diabetes mellitus. And this has been shown both in Danish populations and internationally. Most of these populations are from high-income countries. So you can just assume that this is also the case for low and middle-income countries. Perhaps even a higher burden there. Now, there's also increased risk for kidney end-stage failure, such as shown here in this Norwegian population, and also an increased risk for hypothyroidism after preeclampsia. Now, the only good news may be that women who had preeclampsia seem in several population-based studies to have a less risk of breast cancer, but that has only been shown in women who had preeclampsia when they had a male fetus in their womb. And you probably all know that placenta is working actually a bit differently if the fetus is a boy and a girl. So it's not without any biological explanation, this finding. Now, of course, many of these risk factors, as diabetes and kidney disease, also have increased risk themselves for increasing the risk of maternal cardiovascular disease. So these risk factors are at play together. Now, why are we interested in cardiovascular disease? Obviously, because it's a global burden. And it is a leading cause of death in most countries across the world, also in India. And it's the most important cause of years of lost life. I personally thought that was breast cancer previously, but it turns out it's actually cardiovascular disease. And women have traditionally developed cardiovascular disease 10 to 15 years later than men. They have more atypical symptoms, with less often angina before myocardial infarction. That might have to do with them having smaller, not the typical plaques that men arteries may have. But this may also become a problem, as their symptoms may be more vague and less to understand for doctors. So some studies show that young women are more likely to die of the first heart attack than men. Now, the good thing is that the preclinical stages of cardiovascular disease begin very early in life, and these risks are modifiable. So, since 80–90% of all women across the world bear at least one child, pregnancy is a golden opportunity to improve women's long-term cardiovascular health. And we post with many others authors saying that pregnancy is an underexploited cardiovascular stress test for women, and prevention at a young age is more efficient when before one has actually clinical hard endpoints. So what we're seeing is an increasing problem across the world. This is a study from the United States of America showing that in red, that the rate of women hospitalized for their myocardial infarction is increasing among the young women between 35 and 54 years, whereas men seem to have more stable curve. They haven't seen that same increase. And that means this young group of women have a high one-year mortality of 10%. And they often also have more comorbidities than men have. And the reason for this increase is likely, as you all know, the global epidemic of obesity and more physical inactivity among persons in general. But it seems to be the same finding also in India. I found this paper from Lancet Global Health from 2018, also showing the same trend in India with an increasing mortality also among women, and that increase is higher than what has been seen among men. Now, we all want to know, but why do we have this association between the pregnancy complication, such as preeclampsia, and later cardiovascular disease? And of course, you all know that preeclampsia has a basis in placental dysfunction, which also is the case for fetal growth restriction and also many cases of preterm birth. And these obstetrical outcomes also have an association to future increased cardiovascular disease risk for women. But there is no question that both cardiovascular disease and preeclampsia share common risk factors. Physical inactivity, diabetes, overweight, hypertension, and dyslipidemia is both a risk factor for cardiovascular disease and for preeclampsia. That does not exclude that pregnancy in itself also may help to accelerate atherosclerosis, microvascular and structural cardiovascular changes, and perhaps induce permanent metabolic effects. And the way we think that happens is through systemic inflammatory responses, and fetal dysfunction, insulin resistance is our common pathways. So if you look at Norwegian populations again, it turns out that if we adjust for all the pre-pregnancy risk factors for preeclampsia, the association between preeclampsia and cardiovascular disease is a bit less, lower. But it doesn't disappear, this association. And we did a study also in the whole of Norway called the MOBA study, and we adjusted even for breastfeeding and lipids and everything you could think of also after delivery, and still we could not explain 1/3 of the increased risk for hypertension within 10 years after preeclampsia. So my belief is that there is something in the pregnancy that increases the risk in itself as well. And what could that be? That is that in pregnancy, as you know, there is a general more vascular inflammation than in non-pregnancy, but that is even more exacerbated in preeclampsia. We have hyper and dyslipidemia in preeclampsia compared to normotensive pregnancies. We have a genetic imbalance that may also drive this association, and metabolic and cardiovascular malformation. You know that the heart is differently remodeled in preeclampsia than in normotensive pregnancies. My group has also done some research on fetal microchimerism, suggesting that the fetal cells that may be long-lived, that are transferred over the placenta during pregnancy, that they perhaps also can contribute to a maternal vascular inflammation later in life. This is speculative, and we hope to give you more results on that in the years to come. So what about genetics? This is a very interesting study recently published last year from Finland. They also had a population-based study with 213,000 women. 8,000 and more of them had preeclampsia, and there were a lot of Paris controls as well. Now what they did is that they had the opportunity to do polygenic risk score on all these women. And then they divided them into 3 groups with low polygenic risk score for cardiovascular disease, moderate and high. And then they compared women who had normotensive pregnancies with moderate polygenic risk scores, they were the controls, to those with different polygenic risk scores and who had had preeclampsia. And this is what they found. My animation is going a bit wild here, is that the brown arrow on the top here, actually the brown curve, shows the women who had had preeclampsia in their pregnancy, and that they also have a big high polygenic risk score for cardiovascular disease. This is coronary artery disease, this group. So the curves in blue are those who also had a high risk of coronary artery disease, but they didn't have preeclampsia. As you can see, if you look at the yellow line at 45 years old, those who absolutely had the highest risk for coronary artery disease in true life were those who both had a polygenic risk score and had experienced preeclampsia. So the risk for coronary artery disease was much lower if you didn't have preeclampsia in your life. And the next curve shows the same for stroke, that those who were the highest risk of having stroke was not only those who had the high polygenic risk, but actually those who had experienced preeclampsia. That is the dark brown curve on the top, whereas the dark blue curve on the bottom had a high genetic risk, but actually hadn't experienced preeclampsia. So in my view, this shows that a history of hypertensive disorders of pregnancy and preeclampsia is more important for a woman's cardiovascular disease risk than just a high polygenic risk score itself. And these differences, they persisted until the age of 80 years in these women. So going back to what are the risk factors then, and this is a Norwegian population-based study showing that high blood pressure and high BMI could explain 70% of the excess risk of cardiovascular disease in this group of women. And if you then looked at the glucose and lipids, if they were high, it could explain 25% of the excess risk of cardiovascular disease in these women after hypertensive disorders of pregnancy. So that means that these conventional cardiovascular risk factors, dyslipidemia, hyperglycemia, hypertension, and overweight are important targets for cardiovascular disease prevention after preeclampsia. Now, in this study from Norway again, a different population shows exactly the same, that the risk factors are again hypertension and high BMI and diabetes. But here we show that in the green here, that if you engage in vigorous physical activity, your risk for cardiovascular disease after a hypertensive disorder of pregnancy is decreased, which gives then a good signal to women for doing more exercise. And in conclusion, this study again shows that post-pregnancy follow-up after pregnancy complicated by hypertension is important because it's important to target these modifiable risk factors. They can be altered, and thereby the risk for cardiovascular disease can be decreased. Now, this is another publication from Nature Medicine summarizing that women are especially prone for modifiable risk factors for cardiovascular disease compared to men, which gives women actually a large potential for cardiovascular disease reduction. It's not that you have to have a cardiovascular disease, you may actually prevent it by attacking these modifiable risk factors. And so how should we do that? How should we follow up women after preeclampsia to prevent cardiovascular disease? Now, these women, when they deliver, are from 20 to 40 years old in majority, and perhaps they are not having their first cardiovascular event until they're 50 or 60 or 70 years old. So there's a large time here to intervene and to prevent. So in my view, it's important to empower women and use the preeclampsia outcome diagnosis of pregnancy as a kickstart to optimize own health. So that means one should reduce any existing risk factors for cardiovascular disease. That means, of course, no smoking, try to reduce the weight if one is overweight or obese, and engage in physical activity. And of course, treat any existing diabetes or trying to prevent that, and also treat severe dyslipidemia if it's present, and also, of course, treat blood pressure. And to treat the high blood pressure, one needs to actually measure the blood pressure. So it's important to promote the healthy lifestyle, and if the mother follows it, it might also be that the rest of the family follows that healthy lifestyle as well. So it might be good for the whole family. And it's also important to individualize. Women are not the same, and not even after preeclampsia. So the follow-up frequency and the content of the health follow-up should be individualized according to the risk factors that are discovered, and according also to what the women themselves want to engage in. And we don't have any evidence for using any systematic anti-inflammatory drugs at the moment, like statins or aspirin, because we have not tested that out in this group of women. But any other drugs, such as antihypertensive therapies and lipid-lowering therapies, should be used according to the current indications for that for the population in general, as far as we know for now. And then the point here is that there's a large window of opportunity between delivering at 20, 30, 40 years old until 50, 60, 70 years old. And since the early stages of atherosclerosis are reversible, we can now actually shift this risk pathway. Now, so why are we not just using regular scoring system to evaluate the risk of cardiovascular disease? Well, the short answer is that because they don't work. And this is a publication we did in 2020. We had a group of 235 women that were followed up 1 year after their index pregnancy. We had controls, we had gestational hypertension, we had early and late onset preeclampsia, and women with gestational diabetes mellitus. And we used a regular scoring system, the Framingham 30-year risk score of cardiovascular disease, Joint British Societies for the Prevention of Cardiovascular Disease, and an atherosclerotic cardiovascular disease score. And even though the women after preeclampsia had more risk factors for disease, such as more often prehypertension, high weight, and so on, we did not, these risk calculators were not good enough. They did not identify women as high risk. And that's because they're too young. These risk scores are not made for our population of young women postpartum. You have to be really, really at high risk if they're gonna flag you as a high risk person. So our conclusion to that paper has been that pregnancy complications, such as preeclampsia, need to be considered individually when evaluating the maternal cardiovascular disease risk and the need for postpartum follow-up. And we need more targeted cardiovascular disease risk markers in women with previous pregnancy complications, because the risk calculators we have nowadays are not good enough. So what are the challenges? Well, are caretakers, health personnel, actually aware of increased cardiovascular disease risk after preeclampsia, and do they advise to optimize future health? Well, this study, it's quite old now, 40 years ago, shows in America at least, only 9% of internists and 38% of gynecologists, obstetricians provided any information or counseling to women with a history of preeclampsia. And this study shows that women are motivated of preeclampsia and are willing to participate in trials for follow-up. So we had hoped that in Norway, where we have free of charge for the patient healthcare system, and where all women have their own GP, and men as well, we thought perhaps, well, let's see. And we did a survey that recently showed, we have just published it now with pregnancy hypertension, it showed that 30–40% of women did report any form of cardiovascular follow-up after hypertensive disorders of pregnancy at the general practitioner or in the health system and all. And some of the participants actually cited that they had really to insist on such a follow-up, as their GP said, well, not to worry. And that worries us a bit, that healthcares are not willing to take women's concern and their health seriously. So we are working on how we can improve this. And ICP has, of course, guidelines since 2018 on follow-up suggestions. And in the last version, 2022, we are suggesting that they should be offered women after hypertensive pregnancies lifestyle advices according to international guidelines and diet and physical activity guidelines. But we don't really know what is the best way of following up women. So we have collaborated with the Preeclampsia organization to make like patient-informed sheets where they can enter their own data. And the same has FIGO done. They have made this sheet that you can, my own pregnancy passport, where you can use and enter your lipids, blood pressure values, and so on. And these educational tools might actually help to empower women to get better care. So why it's so important to help women the first year after delivery? Well, it seems that this is a very important time frame to identify women with highest risk for cardiovascular disease. This study from the UK showed that 71% of women after preeclampsia that was delivered preterm actually were hypertensive at 6 months postpartum, and that's a huge rate. We are not finding the same in our Norwegian populations. We found only like 3% after a year with early onset preeclampsia. But we did show that quite many had a pre-hypertensive situation that could benefit from follow-up. And in Denmark, they have the same finding as in Norway. Only about 5% were really hypertensive 1 year after a hypertensive disorder of pregnancy. But look after 10-year time span, then it's up to 32%. So it's important, especially the first 10 years, to identify as early as possible any risk factors that you actually can then modify. So there has been many reports about racial disparities in hypertensive disorders of pregnancy, but also in the cardiovascular disease burden. And that's likely due to many factors, such as socioeconomic differences, healthcare systems availability and the quality of those, and also the awareness of them, educations both for patients and health carers, and environmental differences, such as pollution. And of course, there might be genetic variations, but possibly the most important that there are different burdens of modifiable risk factors, such as high BMI and low physical activity that differ between populations. Now, digital health solutions has been suggested as an opportunity to reduce those disparities. And this study from Sarosh Rana from the US actually showed that that was the case when she introduced a telehealth program at the postpartum timing. She showed that that improved blood pressure control and the likelihood of follow-up visit attendance both between Black and non-Black patients in her community, which gives hope for better postpartum care. Now, we have done some literature review showing that there is really no comprehensive digital health solutions that have specifically addressed the adverse pregnancy outcomes like gestational diabetes mellitus together with hypertensive disorders of pregnancy. Because as I said it from the beginning, both of these situations are associated with increased risk of maternal cardiovascular disease. So therefore, we in my research group in Oslo have invented a new app called the MomCare app. It is a novel mobile health-assisted user-centered follow program. We call it a digital companion. It's not a doctor, it's somebody to kind of coach you. And it's supposed to be used after pregnancy complications such as preeclampsia, gestational hypertension, or gestational diabetes mellitus. So we have registered it at clinicaltrials.gov. It's an ongoing randomized controlled trial. And it's just been recently published how we made this app in Frontiers Global Women's Health. Now, this program that is embedded in this app is based on the public Norwegian Obstetric and Norwegian Directorate of Health guidelines. So we haven't kind of invented new guidelines, but we just transferred them into an app that is easily available for women. And we had users in our co-creation process and stakeholders and clinical experts. We collaborate with cardiologists, we have midwives, obstetricians, we have patient user groups, and IT persons and social researchers and so on. So we were a good group of people doing the best to create the best app. And it has three main parts, this app. One is the first side where one registers and visually tracks the modifiable risk factors by the user herself. She will measure her own blood pressure and enter it. She will enter her blood glucose if she wants to, her weight, her physical activity levels, and any medication or lab values that she wants to. But there's also an educational part. It's not mandatory to access it if one wants to use the app, but it's there for those who want to, with more links to other websites. We have it both in English and Norwegian, this app. So the text is very short. It links to more information websites. And we also have made 4 short videos, such as how to measure your own blood pressure. And then there's a push reminder system to prompt the woman when to measure her blood pressure next time according to her previously registered blood pressure. It's an algorithm that we have made to give her free time when she has not registered any hypertension. And it also prompts the woman to book the recommended follow-up at the general practitioner. Because in the Norwegian guidelines, which are shown on this screen, we have made it in Norwegian and here's also English with English websites. It says that you should have a follow-up at 3 months and 12 months postpartum at your GP to follow up your modifiable risk factors and then make an individual plan for how often we suggest to follow up. So this is between the general practitioner and the woman herself. So with that, we hope to have a more proactive health approach following preeclampsia. To do that, it has several benefits because if we targeted women at highest cardiovascular disease risk, we focus our restricted health resources on those with the most potential to benefit from it. We are trying to reduce the gap between hospital obstetric services and the general healthcare system outside the hospital. And we believe that optimizing the woman's cardiovascular health postpartum will be of benefit also for the next pregnancy and offspring. Because in reality, every woman then, lifestyle optimization will improve next pregnancy outcome. And today's newborn girl is a potential future mother. So this gives transgeneration opportunities for optimizing health and well-being. So at the societal level, of course, giving the population opportunity for education, more physical activity opportunities, and also healthy living areas is also important to provide at the population level. So with that, I'd like to thank you all so much for your attention. I'd like to thank all my collaborators in Norway and abroad for good work together. So thank you, and I hope you have a good day.
Thank you, Professor Staff, for that elaborate enumeration on the long-term implications of cardiovascular health after preeclampsia, and including the transgenerational implications of the same subsequent pregnancy and subsequent medical health. In continuation with this, our next session will be on the pharmacotherapy in the risk modulation of future cardiovascular risk in women with preeclampsia beyond postpartum period. And this will be a cardiologist perspective by Dr. Prabhakar. Before that, I would like to introduce the chairpersons of this session. So one moment, I'll just introduce the chair. So you mute as well. Chairpersons for this session are Professor Dr. Prakash Mehta. He's the Chief of Division of Maternal Field Medicine, Head of Department of OBGYN at Bhagwan Mahavir Jain Hospital. Sir is our President of SMFMI, and he's a postgraduate teacher, fellowship teacher, and an examiner in maternal fetal medicine. Sir has many publications. He was the editor of the textbook Preeclampsia and Enigma Unraveled, a Global Perspective. So has the Best Teacher Award by ANBI, the Best Teacher Award by BSOG, and he's received the Lifetime Achievement Award by the BSOG in 2021. Professor Sarosh Rana, our chairperson, who is the global co-chair of PENI. She's presently the president of ISHIP. She's an international advisor for the SMFMI India, professor of OBGYN, and founder and director at Embrace. Ma'am's presently at the University of Nebraska, Nebraska Medicine. She has many awards and achievements to her credit. Welcome, Professor Sarosh Rana. Then we have Dr. Revati. Dr. Revati is a fellow in maternal fetal medicine from RGHS. She's the chief consultant maternal fetal medicine and managing director at Mirror Health. She is our secretary at SMFMI. She's presently also the global co-chair at ISHIP, and we're very proud of that. She's a co-chair of PEN-I, and she's a director of research at SIG of the pregnancy preeclampsia SMFMI, and she's the executive committee member of ISHIP, and in the past, presently the global co-chair. She was the Indian editor of the textbook Preeclampsia and Enigma Unraveled. She has many publications, achievements, and awards. Of that, our most close to our heart is the Robust study. We welcome Dr. Revati. Now I would like to introduce the speaker, Dr. Prabhakar, sir. Dr. Prabhakar sir is MD DM in cardiology, currently a senior consultant interventional cardiologist at Fortis Hospital, Nagarbhavi and Cunningham Road. Sir is also practicing at super specialty clinics and Amana Medical Center. Sir has several research articles and publications in index journals. He has several paper presentations at conferences. His special interest is on interventional cardiology, clinical research, and health administration and economics. And Sir today will be sharing his perspectives on pharmacotherapy in the risk modulation of future cardiovascular risk in women with preeclampsia beyond the postpartum period. We welcome you, sir. So unmute yourself and you could share your screen. Thank you, sir.
Thank you. At the outset, thank you, Dr. Revati, and the other office bearers, and all the people who were coordinating for this program. I'm not definitely sure if I am qualified to talk to such an august crowd and such a learned audience here. So today, I think most of the things that you could hear in my talk was been already something that was touched upon in the previous talk by the Professor Staff. So I have been assigned a specific task of pharmacotherapy in risk modulation in future cardiovascular risk in women with preeclampsia beyond the postpartum. So it carries lots of words there and lots of responsibility going along. Thank you. That's me, Dr. Prabhakar. I'm an interventional cardiologist and a founder secretary of Karnataka Cardiology Academy and currently the secretary of Lipid Association of India. So what I would like to talk multiple topics, but of course I would be focusing more on where I'm supposed to be. First question is why eclampsia matters. We did hear it in the last half an hour. That's a magnitude of later hypertension, ischemic heart disease, stroke, heart failure, and renal failure. And next is about who needs the drugs, because that's what I have been asked to talk on. So then what would be the why I am here along with you, telling about the cardio-obstetric strategies and what not to promise or what we should understand that what we are empowered to do. And also, I would like to request my gynecological colleagues here, what would be their role, because the childbirth generally tends to end the role of a gynecologist in our society till the lady comes up with some other problem. And most of the things that happen during the pregnancy seems to be forgotten. And what is the clinical algorithm, the practical pathway, and the closing take-home framework. This is what I would like to focus on in next 20 minutes. So we saw this. We have a long period of time between an episode of preeclampsia to a cardiovascular disease. One thing is preeclampsia itself has a large direct effect on the cardiovascular diseases, whereas there are multiple indirect effects that come along as packaged as a part of preeclampsia, which include insulin resistance, obesity, renal disease, hypertension, autoimmune disorders, age, dyslipidemia. So this is where a transition. Most of women used to be younger during the deliveries and lesser comorbids, but what we see today is lots of them are older, and the cardiovascular diseases are coming early, the pregnancies are coming late, shortening this gap here. So unlike whenever we talk about the prevention, we generally talk about the prevention of atherosclerotic cardiovascular diseases. But when we are looking at this subset of population of preeclampsia, first important thing that we need to differentiate is, though we are looking at the prevention of cardiovascular diseases as in atherosclerosis, but the most important aspect to prevent is a heart failure. So when you look at the overall things that we're going to look at when I talk about the cardiovascular diseases, it's not just the cardiac. Cardiovascular, we talk about the cerebrovascular accidents, that's a brain and carotid, pregnancy. Fortunately, nothing much happens. In the postpartum, subclinically, we have a CMITs and later on we have overt strokes, cognitive impairments, and dementia. Similarly, in the eyes and in heart, we have two parts. One is structural alteration leading on to the heart failure, the other leading on to the epicardial coronary artery disease and the microvascular dysfunction leading to the ischemic heart disease. Then we have kidney suffering, eye suffering, liver suffering, which is sort of out of the context for my talk today. So why do I talk on this? All the clinicians know that the preeclampsia increases the hypertension and the stroke risk. This is written, this is dusted down, and all of us know it. I'm using the term clinician here because it applies to any doctor who practices, be it a gynecologist, be it a cardiologist, be it a generalist. And how do we act? This is getting out of allied practice systems, not just out of the clinics. 6 in 10 clinicians never include preeclampsia in the history of CVD risk assessment, including most of us. And 4 in 5 clinicians never provide the CVD risk counseling after the preeclampsia. And clinician wants more education on CVD risk and management after preeclampsia. This is more of a need because many a times if you're not sure about what you want to talk, how we will talk. So we would like to improve upon these parameters as a part of this talk. So for me, a preeclampsia is an early cardiovascular stress test. The timing when we generally don't talk about assessing the cardiovascular risk, pregnancy comes as a natural stress test. And if somebody has a preeclampsia, what are they prone for? 4 times higher risk of heart failure, 2 times higher risk of coronary artery disease. These are extremely high risks, not many. We are not talking about the percentage terms here. If we talk about percentage, it becomes 400% and 200%. So preeclampsia should be treated as an adverse pregnancy outcome that reclassifies the long-term cardiovascular risk. It doesn't end with an adverse pregnancy. The later phenotype includes chronic hypertension, metabolic risk, chronic kidney diseases, and accelerated vascular disease. So the key for take home for the gynecologist would be the key transition is from obstetric complication to preventive cardiology opportunity. Is all women with preeclampsia same? No. Risk is not uniform after the all preeclampsia. I need to know the risk before I talk about the pharmacotherapy. So who are at the higher risk? The early onset preeclampsia. Most adverse long-term cardiovascular events and the higher recurrence burden. Then the people who have a severe preeclampsia, the severe futures, which suggests the more endothelial and hemodynamic injury, rising later hypertension and CVD conference, people with recurrent preeclampsias, and people who have a persistent postpartum hypertension, those with associated metabolic disorders like obesity, dyslipidemia, diabetes, sleep apnea, and the people who have a renal involvement during the preeclampsia, like proteinuria, AKI, or CKD. These are the set of people who are at a much higher risk of cardiovascular complications. And probably they should become the must-treat kind of a subset. The most important question lies here. Professor Staff also touched on it briefly. How do we assess the risk? Most of the cardiovascular risk calculators that we use today talk about the women above 40 years of age, and many of them are not as powerfully predictive as in women as they are in the men. But then we need something. What is useful? Euroscore 3 is applicable to the most of our women. But now, considering the global lifestyle of many women, even the Euroscore 2 could be applicable in the set of typical gynecology patient that you would see in Bangalore city, like an IT professional working at a different time frames. Probably Euroscore 2 would be more applicable to them. The more, again, the one which we are trying now and using more and more, Prevent calculator. This also is supposed to be useful, but then we have been using it for less than a year now. And we also have sort of developed our own risk calculator in India, the Lipid Association of India risk calculator, which is not yet widely available to the most users, which will be soon be available, which I think should be able to predict risk more properly. So with that preamble, what I would say about the risks and what actually happens, the current statements actually supports adverse pregnancy outcome identify a woman at higher lifetime of risk, cardiovascular risk. and justify a structured postpartum to primary care transition. That statement is clear. What does the society say? AHA, American Hypertension Association, postpartum guidance recommend BP optimization, lifestyle therapy, lipid and glucose screening, if not up to date, and renal assessment when indicated. And for treated chronic hypertension, target below 130/80. And no major guidelines recommend a lifelong pharmacotherapy solely to because prior eclampsia and otherwise low-risk women. So does that mean I should stop my talk here? Because there's no major guideline recommended lifelong pharmacotherapy. But guidelines always talk about the general population. But here we are all looking at some specific population and an individual patient alive, which is asking me the questions. And I don't want to be, at least as far as possible, wrong, either in treating the patient. Also, I don't want to be wrong on making patients suffer the adverse drug reactions, because unlike lifestyle, drugs have their own adverse effects. Drugs have their own perceptions, patient perception. You prescribe a antihypertensive, patient will come back saying that they are getting a dizziness or something. And anything that happens to them, including a road traffic accident, is attributed to the medicine. So we need to be very, very careful about the individualizing therapy. So what kind of evidence I have if we want to treat somebody? Because we all know there are a set of people whom we need to treat. So the important aspect to realize here is pharmacotherapy is a phenotype driven. It's not a diagnosis driven. So there's not a subset of 2 or 3 medicines that I write to every woman with a preeclampsia. But I need to decide what phenotype this person is. What questions do I ask? Do we medicate because she's once had a PE? The answer is clear, no. We medicate because the preeclampsia unmasks chronic hypertension, unmasks dyslipidemia, unmasks diabetes, CKD, obesity-related risk, or elevated predicted ASCVD risk. So we are not treating the PE, but we are treating these risk factors. What implication does that have? Preeclampsia acts as a risk enhancer and a referral trigger, especially when the conventional risk score looks deceptively low. This is very, very important. See, many a times, even we as a cardiologist, we see a young lady in her 30s, we look at her cholesterol and we listen to the history, and then we prescribe something saying a non-cardiac chest pain without bothering to assess the risk. And majority of these women who have just now delivered, are about to deliver, looks healthy, looks low risk at the diseases, but unmask all that. So when we decide this, what we have evidence for? Risk factor control using the standard primary prevention drugs. This has no doubt. But the weak evidence, preeclampsia specific long-term drug therapy independent of usual indication. And my practical stance will be escalate earlier when the history of preeclampsia accompanies the bad risk phenotype. This is important. See, somebody who has a 130 LDL, I may say, okay, let's wait for some time and low. But if somebody has a history of preeclampsia, I would be more concerned and start treating. So that would be my approach to the pharmacotherapy. So when I go to the pharmacotherapy, I am mainly looking at treating the chronic hypertension and preventing the heart failure. That's what I told in my third slide. Here, my main concern is to prevent the chronic hypertension and the heart failure, then address the dyslipidemia and other risk factors. So antihypertensives are the most common long-term therapy. In whom to continue or when to start. Persistent postpartum hypertension, beyond 6 to 12 weeks, we have to continue the therapy. Stage 1 and stage 2 hypertension with overall risk amplification. Chronic hypertensive before pregnancy, are people who have LVH, albuminuria, CKD, or diabetes. These are the people whom I would like to continue antihypertensive therapy. And also what changes? The kind of medicines we use. Generally, there are lots of contraindications during the pregnancy, but the same is not true later in the life. So what are my preferred long-term choices in the antihypertensive medications? I would prefer to use an ACE inhibitor or the ARB for a non-pregnant woman, especially more so if they have a CKD, diabetes, or the LV dysfunction. So effectively telling me the most people I would like to use ACE inhibitors are ARB. And for us, the availability drugs are very easy in comparison to many of the Westerners who would have to rely on some specific drugs. And now comes and I'm doing it in an early phase. If this woman is breastfeeding, what can I use? Enalapril and the captopril are compatible with breastfeeding. For that matter, most of the AC inhibitors are compatible with breastfeeding. So ARBs are generally avoided during the lactation. Okay, this is one important statement I wanted to carry forward because I need an ACE inhibitor or the ARB to risk reduce significantly in this population. But in lactation, I would like to avoid ARBs. Once we use the ARBs and the ACE inhibitors, if still there's no control, we add on calcium channel blockers and the thiazides as an adjunct therapy based on the phenotype. This one slide talks about everything on the antihypertensive suggestion. So suggested antihypertensive therapy pathway beyond the 4th trimester is 6 to 12 weeks, confirm whether BP normalizes, verify home or ambulatory measurements, and assess adherence. Persistent hypertension, transition from the obstetric BP control to chronic hypertension management, and with renal function and the proteinuria review. Drug selection, we spoke about it. Then again, if a pregnancy is planned, that again becomes an important factor to consider. If the next pregnancy is planned, switch teratogenic agents early and establish the pregnancy safe regimen. This is what I need to tell you about the antihypertensive therapy. The next is statins. Again here, no automatic prescription of statins, though we know that there's an extreme level of endothelial dysfunction in the women with preeclampsia. If I look quantitatively the endothelial dysfunction, I don't see any other disorder, including diabetes, where there is so much of an endothelial dysfunction as I see it in the preeclampsia. But then the pathogenetic mechanisms are slightly different, many of the immune modulator and other things. So it doesn't become an automatic prescription for a statin. What I would like to do, think about the risk enhancers. Why they matter? Preeclampsia is associated with a later coronary atherosclerosis and can reclassify the perceived lifetime risk. So I would say that for atherosclerosis, you will have to, whatever calculator you use, multiply it by 3. Though the increase in the incidence is 2 times, the increase in the risk is 3 to 4. So we would multiply it by the 3. History of preeclampsia can support the earlier discussion of statins when LDL-C is elevated or global risk seems borderline. This is especially relevant when other enhancers coexist, like a family history of atherosclerosis, cardiovascular disease, diabetes, CKD, metabolic syndrome, or premature menopause later. What not to do? These are the factors that I would consider. But after having considered that, what I don't want to do not prescribe the statin indefinitely just for a prior preeclampsia history without the lipid or risk-based education. Stop and reevaluate before conception because standard lipid-lowering decisions must align with the pregnancy plan. See, this is not just stop and stop. Stop and reevaluate. And use the shared decision-making in the younger women whose 10-year risk underestimates the lifetime burden. This I told you, we need to use different calculators and the different approach, and still we are in the learning curve there. So practical statin decision frame, clear indication, established dyslipidemia, diabetes, CKD, high LDL-C are calculated risk warranting the treatment. Young women, borderline decision. Young women with prior or severe recurrent preeclampsia plus multiple enhancer, P history can tip towards the early therapy. Not indicated if normal lipids are there, low overall risk and no additional enhancer, and active pregnancy planning without another reason. For the gynecologist, the key action is to flag prior P prominently in the referral note because the standard risk calculators often underestimate the long horizon risk in the women under 40. So you need to tell us, look, this lady has a preeclampsia, and take more care about this lady when she visits a physician or a cardiologist. Then you are all used to giving aspirin to the patient who is of high-risk pregnancy, and I think it's 100% prescription in the women with a preeclampsia or a high risk of preeclampsia to prevent preeclampsia. But what happens postpartum? Antiplatelet therapy has almost no routine long-term role. Okay, this is contradictory to what many clinicians believe. Low-dose aspirin is well established for preventing preeclampsia and subsequent high-risk pregnancies when started antenatally, but not as a routine lifelong cardiovascular prevention after preeclampsia. The postpartum aspirin trials exist because the question remains unresolved, which means evidence is not yet strong enough to standard long-term use. Outside another indication, such as established CVD, selected very high-risk primary prevention, or antiphospholipid syndrome, aspirin should not be routine. Useful future pregnancy prophylaxis, uncertain in the immediate postpartum BP recovery strategies, not a routine long-term primary prevention just because somebody had a preeclampsia. So there are many reviews like this where the aspirin is not found to prevent the future adverse cardiovascular events. So as of today, unless somebody has an additional indication, again, the aspirin for the secondary prevention of cardiovascular diseases, no. Then comes, as we said, glucose lowering and the weight loss drugs, which many of our gynecology friends themselves are using. What about SGLT inhibitors and the GLP-1 RAs? So these drugs are relatively newer ones. So as I talk to you here, there is no specific preeclampsia outcome data for the lifelong use of SGLTs and the GLP-1 RAs, but valuable when indications emerge, such as type 2 diabetes, obesity, CKD, heart failure, are a very high cardiovascular risk. They may be especially relevant because many women after the preeclampsia develop an adverse metabolic profile early, especially the obesity and diabetes become very common. And though we don't check the lipids, many of them have a very high LDL levels. So with this, the SGLT2 inhibitors and the GLP-1 become quite relevant. Clinical caution, use only after the breastfeeding and the reproductive planning discussion, depending on the drug class and the region-specific labeling. Again, we don't have a very clear data regarding the use during the lactation for most of these medicines, though there is some information emerging. SGLTs can be safely used during the pregnancy and lactation, but we need to be cautious about the region-specific labeling. They are adjunct to risk phenotype, not substitute for the BP control and the contraception planning. Cardiologists and gynecologists should coordinate around the future conception windows when using these drugs, which don't have a very clear indications and the contraindication in a given subset. So the last thing that I would be talking about when I'm talking risk factor reduction is renal injury. Any form of renal injury, whether it's an acute renal injury or a chronic renal injury, has lots and lots impact on the cardiovascular outcome, be it a heart failure, be it atherosclerotic coronary artery disease. And what happens? if they have a renal injury. And you all are agree with me that there is no other disease as much a renal injury as a preeclampsia. So what would I need to do? Check the creatinine, albuminuria, proteinuria, and persistence of renal dysfunction after the complicated preeclampsia. This also happens often. How do I treat it? ACE inhibitors or the ARBs become attractive in the non-pregnant women with proteinuric or the diabetic kidney disease. And of course, regarding ACE versus ARB, the discussion I used during the hypertension would be useful here also. Escalate, consider nephrology plus cardiology when the CKD or the persistent proteinuria remains. Preeclampsia with AKI, persistent proteinuria, or pre-pregnancy kidney disease should not be seen as a resolved obstetric event. It's often the cardiorenal phenotype requiring the long-term preventive therapy and the pregnancy-safe medication planning. And whatever we spoke in the last couple of slides apply to this subset of patients, maybe with the 2x propensity or the commitment. So those were the 4 or 5 class of medicines which I wanted to talk to you in the pharmacotherapy. But unlike a clinician practicing a pure cardiology or the medicine, here as a gynecologist, drug choice must always account for the next pregnancy. Women with hypertension should generally avoid estrogen-containing contraception when the blood pressure remains elevated or treated. ACE inhibitors, ARBs, statins, and several cardiometabolic drugs require preconception review and the timely discontinuation or the substitution. Gynecologists are often first clinician who can prevent the fetal drug exposure by asking the simple question, could you become pregnant in next 1 year? One chart, one note, state future pregnancy intent, one referral note, last current drugs and the BP trajectory, and one medication review. Switch teratogenic agents early, not after conception. So one chart, one referral note, one medication review is a must for any woman who is likely to plan a pregnancy, not who is pregnant. Please know that drug choice must always account for the future pregnancies planned or unplanned. Who should move early to the cardiology or the cardio-obstetrics? Again, the same, persistent hypertension, severe or recurrent early PE, organ injury, metabolic clustering before next pregnancy. And again, the one important part which we did not touch upon in the previous slides is symptoms. Anybody, however low risk they look like, but if they have dyspnea, chest pain, edema, palpitation, or the exercise intolerance, you should immediately refer them to a cardiologist. How pharmacotherapy changes across the real world profile. As I started saying, it should be a phenotype based. This is what it looks. Look at these 3 cases, which are typical patients you will see every day. A 31-year-old prior severe preterm preeclampsia, now normotensive, LDL is normal, no diabetes, comes to me for consultation. I would say no routine lifelong drug. What I would still advise him, surveillance, lifestyle, annual BP and the metabolic review, preconception counseling. So no drugs. Another lady, 34-year preeclampsia. Now she has a persistent blood pressure of 146/92 and has a microalbuminuria. That means I'm looking at the hypertension persistence, I'm looking at the microalbuminuria. What would I do? I would use either an ACE inhibitor or the ARB, antihypertensive plus renal monitoring, contraception, and the pregnancy-safe plans. That is how it would look. And the case 3, a 38-year-old recurrent preeclampsia, obesity, diabetes, LDL of 156 milligram per DL. So she's got a multiple risk. She needs a multi-risk drug prevention. I would start her on the statin, diabetic therapy, BP control, weight strategy, tighter cardiology, follow. Almost all the class of drugs that I mentioned would be prescribed to this case. So this is how my approach to therapy would be there. Mistakes that increase the misprevention, BP normalized, problem over, misses later chronic hypertension and the metabolic trip, young women, low risk, 10-year calculators are not useful, give aspirin long-term, not evidence-based, statin for every PE, too simplistic. No need for a renal review is common and that changes the drug choices. Contraception is separate, actually central to the safe antihypertensive and the lipid care. These are the factors where we should not miss the opportunities of treatment. What high-risk pregnancy clinics do that will help a cardiologist? Document the APO clearly, measure and remeasure the blood pressure, order the basic risk screening, review contraception and the pregnancy intent, refer the phenotype, not just the history, like persistent hypertension, CKD, diabetes, obesity. Symptoms are the recurrent preeclampsia. These are the cardiology. 5 messages I want to leave you all. Preeclampsia is a powerful long-term cardiovascular risk factors, especially for the heart failure and the chronic hypertension. Beyond postpartum period, antihypertensives are the most evidence-aligned pharmacotherapy because persistent hypertension is common and modifiable. Statins, diabetes drugs, cardiorenal therapy should be used as a standard indication, but preeclampsia should lower the threshold for referral and risk discussion. Routine lifelong aspirin after the preeclampsia is not supported. Every medication choice in reproductive age women must be integrated with contraception in the future pregnancy plans. Despite the robust evidence, the structural and functional cardiovascular and cerebrovascular abnormalities, there is a paucity of randomized control trial data. Future research is needed, but whatever I spoke in last half an hour is what we could do as of now. These are the few references that I used to prepare the slides. So cardio-obstetric starts where the obstetric ends. Identify the phenotype, choose the risk-based pharmacotherapy, and then plan the next pregnancy before it happens. Thank you.
Thank you very much, sir, for that elaborative discussion on the drugs that can be used postpartum, antihypertensives, antiplatelet statins, and also for covering contraception, more of obstetrics, gynecology, but including it in cardio-obstetrics. Thank you very much, sir. If there are any questions, we'll take them.
Doctor, thank you for your talk. This is Dr. Sangeeta. I just wanted to know if we don't routinely test lipids, but would you like, if we find phenotypically that someone is looking like they would probably have dyslipidemia, do we do the lipid profile? And if then, what is the cutoff for us to know that this is a high-risk patient then?
Thank you. That's one of the most important and the relevant question, I guess. See, today we are moved on where the dyslipidemias have become a disease of the older people. In fact, as a cardiologist, I recommend, and most of the pediatric societies also advise this, the first lipid profile screening should be at 8 years. Okay, and if not done at 8 years, it should be done at least by 12 years of age. But majority of that is not possible. But you as a gynecologist have that power when the patient comes to you for the first time, irrespective of what is your perceived possibility of a dyslipidemia, do a lipid test. It's a must, not just to the preeclampsia patients.
Sir, actually, the dictum has been that lipid profiles will be deranged in pregnancy. So most people don't check. So do we then do a check at first trimester and repeat it, or what is your take on that?
Yes. See, most of the situations where a patient has a contact with a doctor, lipids are not representative. Even in patients coming with an acute MI, for example, for a cardiologist, their lipids are down. And it's other way around for this one. But it is not the absolute values. It's the thresholds to trigger therapies, which are very, very clear. Irrespective of what stage of pregnancy, what complications of pregnancy, if there's a dyslipidemia, it triggers the thresholds. Of course, you may not end up putting them on the statins. We would have to do a global risk assessment and then recheck at every 3 months or so and follow that.
Sure, sir. And sir, this is a new generation question with the whole semaglutide and things like that. In order to optimize pregnancy outcomes, would you recommend their use pre-pregnancy to someone who is morbidly obese and who is showing other metabolic dysfunction? Like preconceptionally, in order to improve pregnancy outcomes, let's say a 25-year-old came with a weight of 110 and a BP of 150, 100, for example, would she be a good candidate for its use before pregnancy?
I did show a slide on that and a common heading of SGLT2 and the GLP-1 analogs. Theoretically, it should look optimal. It has to be a sort of planned conception and plan this thing because we don't know what happens to their pregnancy if they were to become pregnant on medicines. But then if somebody asks me, do we have a study where they made people lose weight using the semaglutide or the tirzepatide and did it improve the obstetric outcome? I'm not aware of any of them. But theoretically, it looks a good option.
Thank you so
Sangeeta,
much, sir, for your valuable
Sangeeta, there
time.
are many cases who are already on this kind of drugs, especially those with PCOS. The only
Yes,
thing
sir.
to ensure is that they do not get pregnant when they are on GLP-1.
Yeah, there's a washout.
That's all you have to make ensure because a lot of PCOS patients, a lot of pre-diabetics or with glucose intolerance, overweight are going through this kind, and it has definitely helped.
So, and the other thing that I would want to emphasize is this lipid lowering. I mean, I'm talking about the lipid levels cutoffs. Obviously, like what Dr. Prabhakar said, if you're looking at the standard guideline, it might look higher. But a person with preeclampsia, say if you're treating an LDL
Yeah.
of 135, you would probably want to treat it at 120. So this is something that you do, which is customized to a preeclamptic patient, and this is not going to be in the books. So I don't think we have a study which says what would be the lipid cutoffs for a patient with preeclampsia. So this, or maybe there may be some calculators. I'm not aware of that. Dr. Prabhakar, do we have anything that can guide us on what should be the lower threshold cutoffs?
We are looking at it. In fact, the target for these women, especially once they cross 40 years of age, is to keep, generally we talk about keeping the LDL below 100
Okay.
for women above 40. But if they are preeclamptic, we want to keep the LDL below 70.
So what guides that, sir? How do you have a, because we don't have access to that, right? How do we as clinicians understand, or should we just say that maybe 20 or 30 points less than the average?
No. See, basically what happens is we classify these people into low risk, intermediate risk, high risk, and very high risk for a cardiovascular disease when we are risk stratifying them. So based on this, we have extreme risk category also now, but those generally go to the people who have already established cardiovascular disease or the stents. Other than that, when a person goes from a low, we say up to about 130 is fine. Intermediate risk is up to about 100 is fine. Then when we come to the high risk, we talk about 70, and very high risk, we talk about the 50. So whatever risk assessment you do using whatever methodology, if they have a preeclampsia, you go one level
High
higher.
risk. So it becomes high risk.
Somebody who is an intermediate risk will become a high risk. Somebody who is low risk becomes an intermediate risk.
Understood. Thank you.
Now, what we need to remember is that every preeclampsia is a syndrome. It's not a single disorder. There could be autoimmune background to it. There could be a lipid background to it. There could be a diabetes background to it. So individualization should be the mantra.
Yes.
One size will not fit all.
Absolutely.
So would you recommend lipid screening routinely for postnatally, let's say preeclamptic at 3 months postpartum?
Yes. In fact, we would recommend at 2 months.
Okay.
Is what would be because we don't want to miss that other opportunity of 1 month also.
True.
6 months is 6 weeks is where we expect most of the pregnancy related physiological changes to revert back.
Thank you, sir, for your very informative talk.
Thank you, ma'am.
Hello.
Yeah, Akshita, go ahead.
Hello.
So Dr. Gauri is trying to say something.
Yes, ma'am. I would just, I'm Dr. Gauri Karandikar from Nasik Obstetrician. I would just, wonderful presentations that we have been hearing since the morning. Just would like to add one point here as an obstetrician that FIGO, that is our international body, now has called something which is called as a FIGO passport, postpartum passport. Now that is the postpartum passport. We are supposed to, follow up all these patients with chronic disorders like hypertension, cardiac disorders, or any obesity, diabetes. They have given a proper follow-up system for obstetricians to follow up these patients so that, like sir said, we should follow them at 8 weeks and 12 weeks. There is a nice passport which anyone can download. So this is, I thought, as an obstetrician, all those who are listening, they can go to the net and avail of that and use it for their postpartum patients so that we don't miss these patients who come with chronic hypertension or diabetes later. Thank you so much.
Yeah, thank you, Dr. Gauri. I think you brought out a very nice point. From SMFMI also, we are trying to bring in app so that these patients could be followed up. That's in the pipeline. But till that comes, I think this passport is definitely a good thing to use by all the general obstetricians.
Yeah,
In
thank you so
fact,
much.
only evidence-based therapy that has significantly changed the cardiovascular outcome in trials is a web-based follow, if not physically.
True.
Thank you, sir. Thank you, Prabhakar sir. Thank you, Prakash Mehta sir. Thank you, Gauri ma'am, Sangeeta and Revati ma'am. Thank you for that discussion. Dr. Makaran Rane, we will answer your question in a while, probably on the chat box. Now we'll move on to the next session, which is on where Dr. Revati will tell us what's new in Penai and what are we doing and what are we looking forward for in the next few days coming up. Over to you, Dr. Revati.
Thank you so much, Akshita. And I am so glad that I'm actually presenting to this August audience. Chitrakala, are you ready with the slides? I just want you to present. Yeah, okay. So we are talking about Preeclampsia Education of the Nation, India, which is the flagship project of the Society for Maternal Fetal, of the Society for the Maternal Fetal Medicine India. And for all the audience who have joined newly, I want to introduce this project. Basically, this was launched in 2021 on World Preeclampsia Day, which was on the 22nd of May. And the global co-chair was can I go back to the previous slide, Chitrakala? Yeah, is Dr. Sarosh Rana, and who is the current president of ISHIP, and she is the chair of the OBGYN at the University of Nebraska. And for the Indian co-chairs, we have Dr. Prakash Mehta, sir, who is the president of SMFMI, and myself. The next slide, please. Now, we always have the segment about what's new about Penai in this episode. In fact, VLSPE is a program which is an extension of the Penai project. I mean, after the basic course, we encourage that all the delegates get updated with the VLSP episode, which is absolutely free and can be accessed by delegates across the world. Next slide, please. Yes. So basically, what Penai intends to do, it's about transforming preeclampsia care in India. It's a collaborative effort between the Society for Maternal Fetal Medicine India and the global body, which is the International Society of Study of Hypertension and Pregnancy. It's a hybrid education model. It has both virtual and on-site training. It focuses on high-burden regions in India as well as neighboring countries. We have about 951 healthcare professionals who have been trained and empowered till date. Current emphasis is on implementational strategies. We are moving from education to implementation relevant to clinical practice. So it's all about transformation. Next slide, please. Now, how does it impact high burden regions? Basically, there is the standardized education. So the PEN core team from India, along with the ISHIP, leads expert-led training and certification. The global reach, we are targeting SAARC countries and other LMICs with high preeclampsia disease. Transformative impact, this is to improve maternal health outcomes, reduce mortality, and promote best practices in preeclampsia management, which is standardized. Our future ambition is to plan for implementation in the Middle East, Africa, and South America, along with SAARC. Next slide, please. What we want to emphasize is that we have about 951 empowered delegates span India, Bangladesh, UK, and Afghanistan. These are the specific breakups. I will also tell you how we have included this. Included the online, on-site, conference, workshop, all format and webinar formats. Next slide, please. Yes. And we also have something called the virtual interactive sessions. So people who have graduated and are successful can also, all of them can attend the virtual interactive session and out of which the graduates ask specific questions on a direct Zoom meet where the co-chairs will answer specific questions which are going to impact their clinical practice. So this has been extremely helpful, especially by the feedbacks that we have received, because education translates into actual problem solving for clinical practice. So we've had people from many states of the country as well as many parts of the world who have actually participated very actively through the VIS program. Next slide, please. Yes. As far as the Penai progress, this is the very famous step ladder diagram that I want to put forth, and we are adding a step every time I'm presenting this module. So we started this series on the 22nd May 2021 Penai online, and this was actually launched for the World Preeclampsia Day. And then this was entirely an online program because this was started during the COVID times. Then we subsequently moved on to what is actually the VLSPE, that is nothing but the virtual learning series program. And now we have the third episode. This is to complement what the delegates learned during the Penai series. And we were actually able to get the iShip World Congress as an extension of the Penai. We did the conference programs, which we started with the Tamil Nadu Federation of Obstetrics Gynecology state level conference, which was a big hit, which was an on-site program. We did on-sites with several medical colleges as well as academic societies. And we went to several places across India. We also did the webinar versions, trying to capture people from the north as well as the south of India separately. And we also provided Penai updates in terms of the pearls of wisdom, which was actually given online on emails to all the delegates. And we proposed to extend it beyond India in a very structured fashion to the SAARC countries, the Middle East, Africa, South America, which is actually in the pipeline. Now, as part of the PEN project, we also released the textbook on preeclampsia, and which was actually from the Indian as well as the global perspectives with IZOM. We also kind of groomed the Suraksha PE initiative, which was again launched during the iShip World Congress to build in patient support groups for preeclampsia. We presented the Penai data as an oral presentation in the Chicago World Congress of the iShip. And currently, we're working on the manuscript. We are looking at several other extensions, which I'm going to talk to you a little later about PEN biomarkers. And we're also looking at enrolling several members across the country through the PEN initiative, through the SMFMI. So a lot of things being done along the PEN umbrella, and I'm sure there's more to come in the next few episodes as well. Next slide, please. Basically, the PEN initiative is, these are the highlights of the manuscript. What I want to highlight is currently we're working on what happened between 21 to 2025. And what we actually found was we had both the online as well as the on-site modules. Online modules improved accessibility and scalability, whereas on-site training strengthened clinical engagement and practical training. Interim survey findings demonstrated improved adoption of evidence-based screening, prevention, and management practices in routine clinical care. In fact, what we learned through our 4-year or a 5-year experience, I would say, is Penai highlights the potential of a scalable society-driven education model, because we not only involve the clinicians, we involve the support staff, the nurses, as well as the Ayush doctors. So it is an educational model for strengthening maternal healthcare capacity in LMICs, and the same can be extrapolated not just for preeclampsia, but also for other high-risk pregnancy issues. Next slide, please. This is the highlight of the manuscript. We also did a pan-India survey, one on clinical practice, which is going to be included as part of the manuscript, which we actually found that a lot of people benefited after Penai education. And recently we did a survey to find out what was the awareness on screening and prediction to our Penai delegates as well as Penai Associates. And what we actually found was, because of this education, we found that there was a strong clinical acceptance of first trimester preeclampsia risk assessment models. There was significant variability in current screening approaches and biomarker implementation, but still the awareness was very high. There was delayed antenatal presentation, which was identified as a major barrier. Not everybody is going to come to us in the first trimester, but how are we going to empower our clinicians to identify those who would develop preeclampsia, even if they're going to see them in the second trimester? There was high awareness of angiogenic biomarkers with limited routine clinical utilization. That was the problem. They were aware of how to use it, but they did not have access to the biomarkers. Major implementation barriers included cost, accessibility, reimbursement, and workflow integration. Strong interest in affordable point-of-care biomarker solutions, because people wanted to use something that they can probably get results very quickly, and expanded education initiatives for providers and patients alike. So it's not just about providers and staff, we have to educate patients as well. So we learned all this through the Pan India survey. Now, this is going to be the specifics, the details, the numbers are going to be presented at the Vienna iShip World Congress, which is scheduled in July of this year. Next slide, please. Then, of course, the VLSPE series, this is the series 3. And we are so glad that all the links are available for easy access, as well as access for free, both on the iShip as well as the SMFMI website. We are so glad that it has actually reached a global platform. The highlight of the series, which is again an extension of the Penai project, is that we are going to get experts from across the world, who are endorsed by the iShip, to give specific talks based on their academic and research experiences. We're going to do this on a weekend, so everybody is going to sit in their setup of their house to actually listen to these valuable lectures. We are going to highlight multidisciplinary teams, just like we had a cardiologist talk about how he would probably, look at pharmacotherapy post preeclampsia. So we would get many, interdisciplinary, multidisciplinary approaches in the management of preeclampsia, which is going to start from this particular series. Next slide, please. Yes. The next one, please. So ultimately, all of these strategies are designed to support education-driven capacity blending and strengthen implementation of best practices across healthcare settings, not just in India, but globally. Next slide, please. So moving ahead, after we did all this survey of, through the Penai, we actually found out that there is a dedicated need for a workshop on angiogenic and emerging biomarkers in the prediction, diagnosis, and management of preeclampsia. We wanted to be expert-led, evidence-based lectures covering recent advances, clinical applications, and involving global recommendations. We want to have interactive panels during this, where we're going to address implementational challenges, feasibility, and optimal resource utilization across diverse healthcare settings. And this was developed in response to what we actually got from the survey. And the course framework and academic structure is currently being discussed through the SMFMI iShip liaison collaboration. We're going to get it out very soon. Certification is planned for registered delegates. So just like how we had the Penai program online and on-site, we're going to have the Pen Biomarkers program, which is going to be online and on-site. And we're so glad that biomarkers could still be recommended in LMICs when they have access to it. It is not a restricted utilization. We could definitely improve the reach of how people can get empowered to use the biomarkers to make sure that they have optimal resource utilization to identify these women who can get stripped. So basically, this is a strategic initiative aimed at empowering clinicians with practical biomarker knowledge to optimize maternal and perinatal outcomes in preeclampsia across the country. Next slide. Yes, so this is our correspondence details. So you can actually email us at smfmi2017@gmail, or you can also write to us at penai2021smfmi@gmail.com. So this was the story that Penn actually took us through from 2021 to 2026. It's been almost 5 years. And there's a lot that we've learned. There's a lot that we want to learn. And there's a lot of education that is now transforming into implementation and research, that we want to just not do it in India, but we want to extend globally in collaboration with our global partners like the iShip. Thank you so much, and happy learning.
Thank you,
Thank you very
Revati.
much.
Thank you, Revati. I again remind all the delegates who are looking at this, please write to the office if you're interested in taking part in any of these educational activities. We will definitely welcome your participation.
Thank you, sir. Thank you, Dr. Revati. Now we move on to our next session, which is the clinical panel on preeclampsia as a cardiovascular stress test. Here, first, I would like to introduce our moderator, our professor, Dr. Prakash Mehta, president of SMFMI. Sir will conduct the panel. Okay, so now I'll also like to take this opportunity to introduce our esteemed panelists, Madam Tarakeshwari from Dr. Tarakeshwari, Madam, from Chief Medical Director, Senior Consultant and Head, Obstetric Medicine Unit at Fernandez Hospital, Hyderabad. Madam, special interests are medical disorders complicating pregnancy, recurrent pregnancy loss, and high-risk pregnancy. Madam's protocols on medical disorders complicating pregnancy in the hospital are widely used by most of us across the country. Madam's also the National Coordinator for NBE webinars in maternal and fetal medicine. Welcome, Madam. Now, I'd like to introduce Dr. Shashikala B. Patil, Madam. She's an assistant professor in Vanivilas Hospital, BMC, a consultant at Radha Maternity and Surgical Hospital and Suraksha Women and Child Clinic in Bangalore. Her interests are in high-risk pregnancy, vaginal surgeries, and minimal access surgery. She's received the Young Talent Award at BSOG in 2020. Welcome, Shashikala, Madam. I'd like to introduce Dr. Pankaj G. Rane, sir. He's a senior consultant, head of Department of Medicine and Critical Care at Narayani Hospital, Nashik. He's the organizing secretary of Mahakritikon in 2015 and 2023. Sir is presently the chairperson at ISCCM. His special interests are in critical care medicine, diabetology, and medical disorders in pregnancy. We welcome you, sir. I'd like to introduce Dr. Vandana Goel, Madam. She is presently working at at Moolchand and Neptune Hospital, Delhi, as a senior consultant. Madam's done her MD, DNB, OBG, FNB from Maulana Azad Medical College, Delhi. Madam's special interests are in obstetric medicine and reproductive endocrinology. She has several publications in her name, and she's done a paper presentation in FIGO 2008. She's also contributed to our textbook by SMFMI, that is the Preeclampsia Enigma, on the Preeclampsia textbook by SMFMI. We welcome you, Madam. Over to you, sir, to conduct the panel. Thank you.
Thank you. And once again, welcome everybody. I'm blessed that I have a very knowledgeable panelists with me today. They are from all across India. The idea was that we get an overall perspective of what is happening across India, and we wanted to spread this awareness all across India. And I must say that all these panelists, without any hesitation, just at one phone call, have accepted to be a part of this panel. So thank you all very much.
Thank you.
Now, there are two leading theories of aging, which suggest that there is a trade-off between increased fertility and decreased human lifespan. That means every time there is a pregnancy, the woman's lifespan decreases. So this theory has been very clearly proved: more the fertility, lesser the lifespan. Now, why does this happen? There are two theories for it. One is called as the antagonistic pleiotropy theory, where they says that certain alleles have beneficial effects on fertility and child raising. It's not just fertility, even the child raising stress. And later, it has got a deleterious effects in midlife at the expense of longevity. So that's one theory. The second one is what is called as the disposable soma theory. Because of the competing demands of reproduction, less efforts are invested in the maintenance of somatic tissue, which is required for a long-term survival. So more you concentrate on pregnancy, lesser the chances of long-term survival. So these are the two theories that have been in vogue for quite some time and have now been proved. Now, the occurrence of cardiovascular disease after pregnancy, not just after preeclampsia, after any pregnancy, may be an indirect measure of this theory. We all know that preeclampsia during pregnancy raises future risk. So the first question to Dr. Tarkeshwari, which is the most common stress test that the most women undergo?
Pregnancy itself is the most common stress test.
Absolutely. Okay, pregnancy causes major hemodynamic and metabolic demand. Normal adaptation equals successful stress response. If there is a complicated pregnancy, it's a failed stress response. Just 1 minute. I'm not able to see my questions well. I'll just change the... Okay. So what are the changes or what special things is required during pregnancy? Or why is pregnancy called a stress test?
Because there is a physiological change in the every system, whether it is a respiratory, cardiovascular, or a renal system, and the woman gets adapted to the physiological changes. So how she is able to adapt to the physiological depends upon her own baseline health. So that's why it is called as a stress test.
Dr. Sashikala, would you like to add anything?
As Madam told, similarly, sir, during pregnancy, there is so much significant change in the cardiovascular system, as put increase in cardiac output, blood volume, reduction in the systemic vascular resistance, and there are some structural changes in the heart where there is increase in left ventricular mass. All the changes in normal pregnancy are reversible. But in case of preeclampsia, on the contrary, there is decrease in cardiac output, increase in systemic vascular resistance, and there are exaggerated changes in the left ventricular mass volume and left ventricular concentric hypertrophy. All these changes are irreversible in preeclampsia, leading to cardiovascular dysfunction.
So this failure of preeclampsia reveals the underlying cardiovascular vulnerability. There's no two doubts about that. When I was a postgraduate, we were invariably told that preeclampsia is a pregnancy disorder. Once the patient delivers, you can forget about it. There are no future complications. Nothing is going to happen. And the father of preeclampsia, Chesley, had also written the same sentence. But now we know that this is not true. Preeclampsia is a lifelong disorder. And once a patient has preeclampsia, we need to be careful for her throughout. This is just a systemic meta-analysis that had come out in 2021. And it very clearly pointed out that those with preeclampsia have a higher risk as compared to those with normal pregnancy for future cardiovascular issues. Dr. Vandana Goyal, next question to you. What do you think is the pathology behind it? Why does this happen?
Good morning, sir. Thank you. So basically, there are two things to it. One is the oxidative stress that we call. There are certain inflammatory stimulus that happens in the pregnancy. Normally, it is there, and when it is preeclampsia, means that it cannot be taken care of. It is like a failed stress. So the changes in that inflammation causes release of certain anti-angiogenic molecule factors like SFLT and endoglin. Then the other thing is the cardiovascular changes. That is where there is increased cardiac output, the increased intravascular volume, and the third thing that happens is the abnormal placentation in pregnancy, where the spiral arterioles are not able to cover the trophoblastic invasion that is delayed.
Absolutely. So basically what happens is there's a diastolic dysfunction coming in, which could persist for life. What exactly is the pathogenesis of this cardiovascular problem, Dr. Tarkeshwari?
I feel there is it is the endothelial dysfunction as well as the cardiovascular dysfunction. With the background of the placental ischemia, and also there is an imbalance of the angiogenic factors. And if this woman has associated metabolic syndromes, they all will contribute to the pathogenesis.
Absolutely. You've rightly pointed out that Between the cardiovascular disorders and the preeclampsia, obesity, dyslipidemia, insulin resistance, and excessive inflammation with metabolic syndrome are all common factors. Okay, and there are many articles which have proved that. This particular article, which came in 2023, also pointed out the same thing. So with this, we quickly go to one case. This is a 24-year-old Gravida 3 para 2 living 0 with 32 plus 1 weeks of gestation with a history of preeclampsia and IUD in previous pregnancies. Previous 2 pregnancies, IUD with PE at 7.5 months of amenorrhea, scan done showed 29 weeks gestation with a BPP of 4/8. Placenta was otherwise okay. Early onset preeclampsia without severe features was what was diagnosed, and she was at that particular time APLA negative. Her present investigations were reasonably okay except for an elevated LDH. Her PLGF was 136 and her NST was reactive. So this is her NST, her Doppler, and this is her ECG for this particular patient. She had to be delivered early, 1.48 kg. Apgars were good. Placenta, of course, was adherent because of her previous history. And both the mother and baby finally went home. So with this, we go to Dr. Rane. What are the short-term cardiovascular risks? When I say short-term, I mean during pregnancy and immediately after pregnancy. What are all the cardiovascular risk factors, Dr. Rane?
Good morning. Short-term cardiovascular risks are mainly due to increase in the blood pressure. This could be increased blood pressure will cause, we can get hypertensive encephalopathies, we can get eclampsia, we can get in the form of seizure due to cerebral edema. Commonest intracellular abnormality that we can get is intracerebral hemorrhage, and intracerebral hemorrhage is commonest increase in morbidity and mortality in these patients. We can get even ischemic stroke. One important entity that we need to remember is PRES. It is a posterior reversible encephalopathy syndrome. It will be characterized by headache, altered sensorium, which can have visual disturbances, and patient can have focal neurological deficit. It is mainly due to vasogenic edema, and it is a reversible condition. In heart, we can get heart failure, we can get pulmonary edema, which is the commonest problem. Heart failure, we can have systolic heart failure, diastolic heart failure, even incidence of pericardium.
I think we just lost him there, but it's okay. So he has covered acute hypertensive crisis, heart failure, cardiomyopathy, myocardial ischemia, pulmonary edema. Once in a way, we get arrhythmias, and thromboembolism, of course, we all know is a little common after a preeclampsia. Do we have Dr. Rane back? Because the next question I would like him to answer would be how to manage the acute phase issues. If Dr. Rane is not there, Dr. Tarkeshwari, could you take up this question? How do we manage the acute cardiovascular issues that occur during pregnancy or in immediate
Trying to contact
postpartum?
Dr. Rane, and I think I'll ask him to join back.
Is rejoining?
Just trying to contact him, sir.
Sure, sure. Okay, Dr. Tarkeshwari, please keep speaking. By the time we'll ask him also to answer.
So this lady has birthed, and we are going to look at the acute phase issues during pregnancy, or it is a postpartum how we follow. So during pregnancy, the management of the hypertension itself to stabilize the mother with the antihypertensives, and also to do a baseline echo to look at the cardiac dysfunction and the acute management of, if she is in pulmonary edema, we should be able to manage pulmonary edema. And to prevention of preeclampsia, always we use the magnesium sulfate prophylaxis. And with stabilizing the mother, this particular scenario, I think there is a hemolysis because LDH is on the higher side. I would like to know about her hemoglobin and also the coagulation parameters, arrange for blood products, and the timely delivery. That is what at the acute phase I feel.
Absolutely. So, but what we need to remember is that you may put the patient in ICU today, but the post-ICU and long-term follow-up is where we are failing. We are not giving them adequate care in this particular period, and we need to make sure that they get that. Now, we already have been talking that preeclampsia is an early stress test, and if the patient needs an ICU care, the test was strongly positive. So any of our preeclampsia patients who need ICU care warrants lifelong cardiovascular vigilance. No two doubts.
Dr. Rane has joined back.
Yes, Dr. Rane, would you want to add anything? Okay, anyway, we have covered this. We'll go further for another question for him. What are the long-term cardiovascular outcomes of ICU admission, Dr. Rane, if you're there?
It will be better if he switches off the video and puts only the audio on.
Yeah, Dr. Rane, you could switch the video off and unmute yourself.
Hello, sir. Am I audible?
Yeah, now you're audible.
Yes.
What are
Hello.
the long-term cardiovascular outcomes
Yeah.
of preeclampsia admitted to
when
ICU?
a patient, so we need to take care of 2-3 things. We need to monitor what are the systems that are involved. We need to do basic lab tests like LFT, CBC. We need to look for hemolysis, renal function, and uric acid that we need to do. And in monitoring, what we need to do is to control the blood pressure. So for controlling blood pressure, we can use labetalol is the preferred drug. Labetalol, we should use a 20 milligram bolus initially, and we can repeat that after every 10 minutes in 20 milligram. We can go up to 300 milligram in first 3 hours. Another second drug that we can use is nifedipine. We can give 10 milligram stat, and we can repeat 10 to 20 milligram every 3 hours.
Sure.
We
Okay.
can
The
control
long
blood
term,
pressure.
how do our patients who have been in ICU behave later on? How many of them might have come back to you at, say, after 10 years with cardiovascular problems? What happens to them long term, those who have been in your ICU?
So there are two problems which can niggle long term. One is the patient can remain persistently hypertensive. That is the one thing. Second problem that these patients can have is the diastolic heart failure that commonly they do have. And as we have seen the renal problems, that patients who have got renal failure, particularly patients if they have got acute cortical necrosis, these people are there is very high risk that they remain depend long term on the renal replacement therapy. That is the main issue. And all these long-term outcomes depends on how was the severity of the preeclampsia and its complication in the index admission.
Fine. Generally, what happens is when there is an heart failure, we are talking of long-term, not immediate complication. The ejection fraction is not normal. But here with preeclampsia patients who develop long-term heart failure, there is a heart failure with preserved ejection fraction. That's one of the commonest conditions that you find there. So we need to keep that in mind and just don't go only on echo. Most of the time, the hypertension will recur within 5 years if it has not gone immediately in the postpartum period. But the other types of CVDs generally take about 10 to 20 years before they start manifesting. So we have a long gap available to us to modify them and ensure that these women live a very healthy life. Again to Dr. Pankaj, what are the long-term cardiac structural defects that you have noted?
So there are two issues because preeclampsia, as we have seen in previous two talks, preeclampsia leaves a lot of long-term footprint on this patient. Commonest problem that we can get is structural heart problem is the left ventricular hypertrophy. There is remodeling of the left ventricle occurs, and there is two types of defects that we get. Commonest would be diastolic heart failure, in which heart will not be able to relax. So there will be increased abdominal artery stiffness. That is the one thing. Second commonest problem that we get is the coronary artery disease. There is almost 2 times risk of coronary artery disease in this patient. Again, this patient will have, because of the chronic diastolic heart failure, there will be increase in the left atrial size and LA pressures. And chronic left atrial pressure, when LA size is increased, they are prone for arrhythmias like atrial fibrillation. So any patient who is developing, he has got history of preeclampsia, he is developing any arrhythmias, we always need to go back and take a history. So this is the main thing that we get. So mainly left ventricular hypertrophy, LV remodeling, diastolic heart failure, and in patients with who has got peripartum cardiopathy, need to long-term recovery depends on in almost 20-30% cases of post peripartum cardiopathy, we get a decreased systolic function in long term.
Absolutely. But as obstetricians, we need to remember two important phrases. One is concentric LV remodeling, and second one is diastolic dysfunction. If you remember these 2 points, then you will fully understand what's going to happen to this patient in future. So what causes this immediate pregnancy complications into long-term vascular disease is driven by persistent mechanistic pathways that initiate or accelerate vascular and cardiac issues. Now, why does this happen? We have got two models currently. One is called as the marker hypothesis and the other one is called as the causal hypothesis. In the marker hypothesis, What it means is that preeclampsia identifies women already at a risk. The metabolic syndrome is already there. The preeclampsia brings it out, and the same metabolic dysfunction, which includes endothelial dysfunction, obesity, hypertension, hyperglycemia, insulin resistance, elevated homocysteine levels, again projects in future as cardiovascular disease. The second one is called as the causal hypothesis, where it says that the preeclampsia causes permanent vascular damage. So one says that preeclampsia just comes out with an already existing risk disorder. The other one says no, preeclampsia is what is causing the permanent vascular damage. As per current understanding, both these models are true. So just to summarize what the acute thing quickly, preeclampsia, endothelial injury, inflammation, persistent vascular stiffness, structural and functional impairment on echo, LV concentric remodeling, diastolic dysfunction, heart failure with preserved ejection fraction. And we need to remember, again, I'm repeating it again, preeclampsia does not end with delivery. The next question to Dr. Vanna Goyal. Now we'll start going into the nuances of various kinds of preeclampsia. What are the key differences between early versus late preeclampsia for future cardiovascular risk? Dr. Vanna, is there any difference or both are same as far as future is concerned?
So it is known that the early preeclampsia, that is before 34 weeks, is considered more serious. So the long-term cardiovascular effects are also more common in the early ones, but still there are not so strong studies to show that. Because as Dr. Staff also showed in her study, surprisingly, the late preeclampsia was showing more cardiovascular with her, because the overall the two things that happen are in common to both of them, the cardiovascular changes as well as the pathogen, the remodeling. Basically the remodeling does not happen so better by the late. The cardiovascular function is comparatively preserved in the late.
Dr. Vandana, sorry to cut in. If you're using two audios, can you please mute at least one of them, because there's lots of echo happening.
Yes, Dr. Vanna, please go ahead. Dr. Vanna, you're muted yourself. Anyway, till Dr. Vanna comes back, remember the early onset preeclampsia, the onset of CVD is earlier, in late onset it is a little later. It reflects pre-existing cardiovascular susceptibility in early onset, whereas the metabolic contribution is more with late onset. So to summarize, early onset risk is earlier, stronger, and more persistent. The lesson for us as obstetricians to learn is that whenever there is an early onset preeclampsia, there is preeclampsia coming in before 34 weeks, do be very careful with this patient for as far as follow-up is concerned. Late onset, even if you miss, it could still be excusable, but early onset, please do not miss. Next question to Dr. Tarkeshwari. If the preeclampsia recurs again during the next pregnancy, is there any change in the long-term risk?
Certainly, I think there is a long-term risk which we are hearing from the previous talks to, like chronic hypertension and renal changes in the renal system. They may have kidney damage, and also if the mother has the metabolic syndrome, we need to look at the risk of stroke also in these women. Definitely, the long-term risk and follow-up of these women is important for all these factors.
Dr. Tarkeshwari, supposing my patient had only one preeclampsia, next time normal, no issues, versus another patient who had one preeclampsia this time, next time also she has preeclampsia, how would you gauge a risk?
So when we look at the recurrent preeclampsia, the maternal risks, fetal risks, and the long-term risks. Suppose the previous preeclampsia with the current pregnancy, if you think it is normal, still we have to be very careful in monitoring as a high-risk pregnancy, because this woman this time may have diabetes. This woman this time may have hypothyroidism, may not have in the first pregnancy. So definitely the current pregnancy, even if it is normal, you have to monitor carefully and look at the associated metabolic syndrome this woman has. And recurrent preeclampsia, we're always on to the edge. She's developing again and she has this proteinuria, and we do the echo, she has this cardiovascular dysfunction. So definitely the long-term risk of developing cardiovascular disease is high for recurrent preeclamptics.
Absolutely. So if there is a recurrent preeclampsia, very high lifetime cardiovascular risk, consider early aggressive prevention. Just because she's young, don't think she's low risk. You have to aggressively do prevention in her. Now, there is another case, a 29-year-old, again back to Dr. Tarkeshwari only. Para 2 had preeclampsia during her first pregnancy, but subsequent pregnancy was normotensive. What are her risks for future cardiovascular issues?
We just ask her to we monitor her even in this pregnancy and postpartum, and we look at her comorbid conditions. Like, as I said earlier, obesity is one, diabetes is one, and dyslipidemia is one. So these three have to be looked into, and then we have to be watchful, and these factors have to be corrected in the postpartum period.
Absolutely. So like this, as Madam pointed out, a later normal pregnancy is a good sign, but it does not erase the elevated baseline cardiovascular risk. The risk may be lower compared to somebody with a recurrent preeclampsia, but still higher than a woman who has never had preeclampsia. So it is worth preactive monitoring and prevention. Dr. Sashikala, what is the influence of HELP on cardiac outcome? Supposing your patient has had HELP syndrome, do you think a cardiovascular outcome is much poorer?
Yes, sir. HELP syndrome alone it might be associated normotensive or hypertensive. There is a increased cardiac worsened conditions are more chances of heart failure, concentric LV hypertrophy chances are very high. It goes to almost 30 to 50% in 6 months to 1 year.
Absolutely. So remember, if your patient have had HELP syndrome, her risks are definitely much more than a patient who has had a simple, so-called within inverted commas, simple preeclampsia. Dr. Vandana, why would HELP carry a higher risk?
So because associated, it has been known that with HELP, there is one thing is the persistent liver. The condition is more persistent even postpartum. The reversal does not happen so quickly with HELP association. And it is more, the liver decompensation is also associated as well as the renal, it becomes more of a cardiometabolic condition, which is worse.
Absolutely. So HELP reflects a more systemic and severe vascular injury pattern. So if there is a HELP syndrome for a patient, then the future disease will definitely present earlier than those with a so-called simple preeclampsia. So remember, preeclampsia is a cardiovascular warning sign, but HELP is a strong warning signal of vascular vulnerability. So there is this big difference between the two. Dr. Tarkeshwari, what is the role of heart as a contributor to preeclampsia?
We need to look at the woman if she already has a pre-existing any cardiac dysfunction, which can be precipitated in pregnancy as preeclampsia. So one other thing which we have to be always careful, and also as told earlier, early onset preeclampsia and late onset preeclampsia, where late onset is more of a cardiovascular adaptation. So I think these are the two theories which can also contribute to the preeclampsia.
Absolutely. So the simple way to remember would be placenta starts the problem, but the heart and the vessel decides how severe it becomes. Okay, so initiation by placenta, further problems, how her heart and the blood vessels are. Dr. Pankaj, why kidney matters in preeclampsia?
As we know, preeclampsia is defined by the proteinuria. So kidney is the primary organ that is involved in preeclampsia, and it starts many things. Mainly preeclampsia, what we get is we get glomerular endosclerosis, and that is the cause for the proteinuria. In kidney, what happens is initially in pregnancy, the glomerular blood flow and the renal plasma flow is 30 to 40% increase. So normally creatine goes below 1. So even a creatine of 1.1 is abnormal in pregnancy. So in pregnancy, what happens is the first injury that starts is a tubular injury, and later the glomerular injury sets in. For tubular injury, first to detect tubular injury will reduce the uric acid excretion. So we can get hyperuricemia much prior to proteinuria, because after tubular the glomerular injury will happen, and that will lead to proteinuria. So we need to monitor uric acid in these patients when these patients have got hypertension. Another important thing is that these patients, as they progress, the vascular injury will set in the renal failure. For renal failure, there are two mechanisms. One can be acute tubular necrosis or acute cortical necrosis. Patients with acute cortical necrosis will have a long-term renal replacement treatment in many patients because their renal functions will not recover. So in kidney, most of the injuries that are there because of the endothelial dysfunction that is occurring.
Yeah, so once the kidney gets involved, it means that there is a severe endothelial dysfunction. And the cardiorenal interaction is bilateral. The kidney dysfunction will worsen hypertension, and the cardiac dysfunction will worsen renal perfusion. So the long-term outcomes are definitely much poorer. Dr. Sashikala, is renal dysfunction linked to higher cardiovascular risk?
Yes, definitely. As discussed, renal dysfunction worsens the cardiovascular risk. As already been discussed, endothelial dysfunction and activation of RAS system, all these leads to worsening of cardiovascular compromise.
Absolutely.
Yes.
So the kidney works as a sentinel organ. You know, we do a sentinel lymph node identification malignancy. This is something like that. This is a sentinel organ which tells you that yes, there is a severe systemic vascular injury. So once that patient has a kidney disorder, definitely the risks are very, very high in future. We should never forget that. And again, a lesson for obstetricians for us to learn is that if your patient has had a renal dysfunction, please treat her a little differently from a patient who has had a simple late preeclampsia. Dr. Vandana, sleep apnea is supposed to be playing a big role. What is the role of sleep apnea?
So, the sleep apnea is actually the extreme end of what they call the persistent sleep disordered breathing. So they say that because the pathophysiology is the same, the increased inflammation, the increased oxidative stress, and the sympathetic overactivity. So people with the sleep apnea are at a higher risk of getting the hypertension and other cardiovascular long-term side effects. There are two indices also which they use sometimes to measure the oxygen desaturation index and the apnea hypoapnea index. That is, and for both, that is, they count the number of times a patient has been in an hour. They count how many times the patient has been apneic. In the when we have the pulse oximeter, then with that we can measure. So
True. So just remember that sleep apnea is a every night cardiovascular stress test. Because every time a sleep apnea occurs, there will be a high BP surges at night. So any patient with sleep apnea, due to whatever reason, maybe obesity, maybe something else, whenever they have a sleep apnea, please be extra careful with them. And now, of course, sleep apnea is also implicated in the etiology of preeclampsia. Many articles have started appearing. We tried to do actually a research project in our hospital also. But unfortunately, we couldn't complete that project because some of the patients were not very cooperative to wanting to go through this test. But definitely I'm going to do it in future. So there is a shared pathway, same endothelial injury, inflammation, and of course the high BP load. So because of this, the patient who has had sleep apnea and preeclampsia will have definitely a very high risk of later cardiovascular disorder. And sleep apnea is now considered as a modifiable risk factor in hypertensive disorders of pregnancy. So you give them a CPAP therapy. Obviously, they're going to improve a lot. Dr. Tarkeshwari, next question to you. Would a woman who is obese have a higher risk for future cardiovascular disorders as compared to a patient who is a little thin?
Obesity itself has a risk of insulin resistance, diabetes, and if you go with the low adiponectin levels, I think they are responsible for increased inflammation, and this contributes to the cardiovascular problems in preeclampsia.
Absolutely. So what happens with an obese patient is that the strain is already higher because of preeclampsia. Now that strain also starts from a higher baseline as compared to a patient who is not obese. So, and on pregnancy, another 30 to 50% of the overload has been added. So all this causes quite a bit of problem. So remember that metabolic syndrome and obesity overlap together to form a metabolic cardiovascular cluster. So that is what ultimately causes the issue. So the background stress is there. On that, the preeclampsia adds a vascular injury, and together it is not addition, but it is multiplication. It is not, like 2 or 3 plus 3 makes 6, but it doesn't happen like that. It becomes 3 into 3 equal to 9. So it's not just simple addition, but multiplication. The lesson for us as obstetricians to learn is that if your patient is obese, please ensure that she loses weight. Next question again to Dr. Tarkeshwari. Why would diabetes and preeclampsia worsen the future cardiovascular outcomes? Why does that happen?
Yeah. One side, diabetes has the increased blood sugars, the hyperglycemia has an adverse effect on the cardiovascular system. And the baseline preeclampsia, if she's already prone to, I think this will compound the effect of the diabetes, if I may to say this.
Absolutely. So what happens is that both this condition have got a little bit of endothelial dysfunction, which gets amplified. Then we know that inflammation also plays a role. Every time there is an insulin resistance, the inflammation is worsened, plus the placental and the metabolic stress both add together. Obviously, a patient with diabetes and preeclampsia is going to have definitely a further worsened outcome as compared to a non-diabetic preeclampsia. Dr. Vanna Goyal, next question for you. If there is an altered split PLGF ratio in this pregnancy, does it affect the long-term outcome?
So,
As compared to a patient who has had normal split PLGF.
as we feel that it has a predictive role, the SFLT and PLGF ratio, it has a very good predictive role in knowing the myocardial injury, and also the subclinical higher risk of long-term outcomes. But the only factor that comes in between is that these values decline post delivery. The levels of the SFLT and the PLGF, the anti-angiogenic markers declines post delivery. So that is the only limiting factor, I would say, in their potential role in the long term outcomes. It needs to be further studied. Though
what happens with the high split PLGF ratio is that it is associated with the severe preeclampsia. Now, once severe preeclampsia comes, the endothelial damage is going to be much more severe. And this severity of the endothelial damage will also cause a future cardiovascular risk to increase. So remember, the split PLGF imbalance in preeclampsia is not only a placental marker, but it is a biochemical readout of the cardiovascular stress, so that it tells us what's going to happen in the future. It's an early measurable failure of cardiovascular stress test, endothelial dysfunction, cardiac remodeling, and preserved ejection fraction heart failure. So all these are, that means if you have a patient whose split PLGF ratio was elevated, please treat her for future risk a little differently from, again, to give an example, a late onset preeclampsia where the split PLGF ratio was not elevated. Okay, so that is the most important thing. Every addition your preeclampsia patient has with along with preeclampsia changes her future cardiovascular risk. Next, one very interesting question to Dr. Tarkeshwari. The fetal sex, whether it's a boy or a girl in utero, does it change the vascular programming and worsen the future cardiac outcome?
The literature supports like male sex. Actually, they have a vascular dysfunction and they are more prone for cardiovascular diseases in the adult life. And the female fetus, I think the risk of preeclampsia is higher.
Okay, so what happens is that most of the pattern of placental function is controlled by an X-linked gene dosage. Okay, and it depends. We all know what is Mary-Lyon hypothesis. When a female has two X's, one X will be inactivated. And so which X escapes on X inactivation and what is the exact sex chromosome composition will all affect the future risk. So inflammatory gene expression is elevated in a male placenta. Implication would be higher systemic endothelial dysfunction. The angiogenic balance in a male fetus, there is more SCLIT1 overexpression. Whereas females, females are generally more stable compared to men, isn't it? I'm sure all our ladies will agree to that. So whenever there is a female placenta, it brings out, it's calmer, unlike a male who's hyper. So the female placenta brings out more stable PLGF expression, whereas male is more S-split. And the mitochondrial dysfunction also adds on to all these problems. So there's a beautiful article which appeared on 24th June 2025. I've put this article here. Any one of you who are interested in knowing more about it can go through that article. Next question to Dr. Vandana Goyal. Now, we have been talking about cardiovascular effect in the mother. Is the fetus who is inside also have a disturbance in cardiovascular health?
Yes, sir. It has been very well studied that the offsprings of pre-eclamptic mothers, they are at a higher risk of early onset at a younger age, the hypertension at a younger age, and also higher risks of stroke and ischemic heart disease. So basically, there have been many studies to prove the physiological alterations. That is, they have studied the human umbilical vessel, vasculogenic factors. Then two things mainly: the vascular effects, the alteration in the vascular effects, as well as the alteration in the cardiac effects. Wherein they studied the left ventricular wall thickness, the left ventricle diastolic, and the higher end diastolic flow, and the systolic, the myometrial thickness. Similarly, in the vascular ones, they study the carotid vessel intima thickness and the umbilical vessel thickness. So all these are very clearly proven that the alterations are there in the offspring, and how much they are correlated, the phenotypic variations still need to be further explored, but definitely there is the higher risk of the changes.
Absolutely. There is something called as the CVH score or the cardiovascular health score, which includes 5 metrics: the BMI, the blood pressure, the lipids, the glucose, and smoking. And it is found that these babies who are born to pre-eclamptic mothers, they had an early child CVH in early adolescence. If you look at the scores on this side, you can see that more than 2 or a poor score, the incidence was much higher in babies of pre-eclamptic mothers. So we must remember that we not only look after the mother, but we also look after the baby. The pediatrician needs to follow up these babies born to pre-eclamptic mothers also very well. Next question to Dr. Pankaj. What is the importance of echocardiography in all this thing?
Sir, as we are seeing now throughout the sessions, that heart has undergoing many structural changes. So echo is important to know that it is most important non-invasive tool. It will mainly detect whether patient has got left ventricular hypertrophy. That will help us in differentiating patient with hypertension with pregnancy and differentiating pregnancy with hypertension. And we have to look at LV remodeling. We can look at LV systolic function. Then main very important thing is we can look at is the diastolic dysfunction from echo. Then we can, there are various other measures like left atrial pressure, left atrial filling pressures that will tell us how heart is functioning and how heart is coping the vascular stress that is occurring because of preeclampsia. In many patients of preeclampsia, when they get admitted in emergencies, they are vascularly dehydrated, but few patients have got vascular overload. So echo will differentiate which patients we need hydration and which patient needs we need to restrict the fluids. So this will in ICU management it will help. Echo is very important in even in a postpartum state to know the how heart is recovering, how heart is remodeling, and how is diastolic dysfunction is progressing. Because as we know, heart failure with preservation is a very important tool. Another important tool is that these patients have got reduced systolic function, which is not picked up on routine echo. And for that, we need to do global longitudinal stent, that is GLS. And many patients have got reduced GLS, and that will indicate that there is a myocardial fibrosis that is undergoing on. Then echo will definitely tell us in doing a lung ultrasound in which we can detect pleural effusion, we can detect pulmonary edema for that. Even echo will tell us whether these patients are prone from developing pulmonary edema. If their LA filling pressures are high, then these patients are prone for pulmonary edema, so we can manage our fluids and drugs accordingly.
Absolutely. So an echo is absolutely essential in pre-eclamptic patients. There's no two doubts about it. But personally, my opinion is that to do a echocardiography in all pregnant patients, I think would be a waste of resources. I wouldn't really agree on that. But every pre-eclamptic woman definitely needs a echocardiography. And we need to remember that echo in pregnancy is a diagnostic tool, not a screening test. When I start using on every pregnant patient, it becomes a screening tool. So I have to use it as a diagnostic tool in patients with preeclampsia. I hope my panelists agree with this because there are some states who are insisting on echo on every pregnant patient.
Absolutely.
Absolutely. So we have a lot of challenges in the management, and there are a few questions on management now. Also, we need to remember that the long-term outcome, the chronic hypertension, more risk associated with preeclampsia in the first pregnancy, and the risk of chronic outcomes have already been told many times. And remember that there is an ischemic heart disease and the previous preeclampsia. There is a linear association with severity. So more severe the preeclampsia, higher the chance of IHD. And of course, genetic factors are always there, and all women with poor prior preeclampsia should pursue a healthy diet and lifestyle. It is a basic, I should say, mandate on all obstetricians to ensure that women with prior preeclampsia are informed about diet and lifestyle. Okay, we quickly go through one or two cases. Case one was apparently healthy. Okay, this goes to Dr. Sashikala, a 34-year-old, 2-year postpartum, history of preeclampsia without severe features, current vitals normal, no symptoms, investigations, lipids, fasting glucose, everything is normal. Should she be reassured or monitored, and how aggressive should the follow-up be?
As of now, as the blood reports are normal, we can reassure about the reports are normal, but she is the candidate who needs follow-up with annual monitoring of blood pressure and metabolic workup she needs. And as already mentioned about lifestyle change and maintaining ideal body weight, all that is very important.
Agreed. So even a mild disease increases long-term risk. I mean, we are repeatedly emphasizing that so that we all remember it. Clinically, she may be normal today. Even after 2 years after preeclampsia, she may be normal, but she has an elevated lifetime risk. So emphasize on lifestyle and periodic screening. The next one, and 30-year-old woman who had severe preeclampsia at 31 weeks. 1 year later, her blood pressure is 146 by 92 millimeters of mercury. What is the most likely interpretation, Dr. Sashikala?
Probably looks like she is going for transition to chronic hypertension as it has seen after a period of 1 year, sir.
So do you think it's white coat hypertension, secondary hypertension due to renal disease, postpartum physiological variation, or is it transition to chronic hypertension?
Probably, I feel it's a transition to chronic hypertension. But if we have a baseline value at 3 months, blood tests, microalbuminuria, all that, we should consider about if we have our checkup, like her routine blood tests and her blood pressure checkup, all that was normal at 6 to 12 weeks, we can consider it as transition to chronic hypertension, sir.
Absolutely. So she's transitioning to chronic hypertension, and this patient deserves a lipid screening. This is a case of subclinical cardiac dysfunction. A 36-year-old with prior preeclampsia 6 years back presents with progressive exertional dyspnea. She's NYHA 2 or bar 3, reduced exercise tolerance, fatigue on climbing stairs, occasional palpitations, no chest pain. Echo ejection fraction is 60%, which is normal. There is a concentric LV remodeling, diastolic dysfunction of grade 1, bar 2, nothing great. Mild left ventricular enlargement. BNP is mildly elevated. Dr. Pankaj, is this early heart failure? And if it is early heart failure, why there is a preserved ejection fraction?
Sir, as we know, definitely this is a early heart failure and this is a diastolic heart failure. As we know, there are two types of heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. And even heart failure with preserved ejection fraction in general population is more than 50%. So we need to remember that even if we have got habit of seeing echo reports and we see LV ejection fraction, if it is normal, we feel heart is normal. But diastolic dysfunction is very common entity, and even in this patient with subset of preeclampsia, it is very high risk for developing. And as we say, this patient is getting occasionally palpitations, his LA is slightly enlarged. So this patient may be getting intermittent atrial fibrillation also. So even this patient closely needs to see what is the LA size. Even this patient may need a Holter monitoring. Why is she getting palpitation or whether she is developing any intermittent atrial fibrillation.
So basically, this patient represents a stress failure of the test of pregnancy preeclampsia. So next question about prevention. A 38-year-old presents with non-ST elevation MI. So it's a non-STEMI. Severe preeclampsia at the age of 29. So this has happened 10 years later. No follow-up since then. Coronary angiography, premature atherosclerosis is present. Was this preventable? Should obstetric history be a part of routine cardiology care?
So answer to this question is what we have studied in last 2 hours is that many people forget that preeclampsia is a major risk factor for cardiovascular diseases. So we don't ask this history in patients who are coming to us with cardiac events. What we ask for is any smoking, any diabetes, or any family history of cardiovascular disease. So this thing, I think, at least more than 50% clinicians are not asking this question. So we need to ask this question, and this is definitely preventable. As we have discussed, that we need to have definitive plan for postpartum follow-up these patients. We need to monitor blood pressure, monitor for any developing metabolic syndrome. We need to monitor with blood test annually, and as the report suggests, then the monitoring should be there. But as this patient had severe preeclampsia, so she was high risk for this. So definitely monitoring last 9 years would have helped us in preventing this. So we missed opportunity in this case for early prevention.
This was clearly a missed opportunity for early prevention, and the blame directly lies on the obstetrician who missed the opportunity of counseling the patient while she was going home. So let us all remember this case forever and make sure that we counsel our patients properly. A quick answer, Dr. Sashikala, what care can be taken in immediate and early postpartum period?
Immediate postpartum period, we already discussed.
Write it on paper about the
maintaining like normal blood pressure. If the BP is going up, especially in day 3 and day 5, BP chances going up are very high. We have to maintain a normal blood pressure, and continuation of medication, antihypertensives is important. And about the risk, immediate complications, we know about thromboembolism, all that care to be taken care of, all that. And counseling about important starting the breastfeeding, especially like long-term breastfeeding, also has a preventive role in cardiovascular diseases. Contraception is very, very important, which needs to be highlighted, and make sure every woman goes with the contraceptive counseling. And about explaining the long-term risk of cardiovascular disease, lifestyle change, maintaining ideal body weight, about the diet, all that matters.
Absolutely. Those who are interested in more, there is a beautiful article on stamp hypertension by Dr. Sarosh Rana. It's available on the web. You can go through that, which tells you how to manage very well in the immediate post-operative period. And when do you refer the patient to a cardiologist and say, okay, my job is now done? Dr. Vanna Goyal, what should be done long-term for a patient after preeclampsia? How do you advise them? How do you counsel them?
So it's like summarizing the diet
Stop.
today. So we start with the lifestyle modification where we maintain the BMI between 19.5 to 30. The regular exercise, which is considered, they have different criteria for moderate exercise, around around 150 minutes every week. The diet, of course, not avoiding the healthy diet, taking a healthy diet, not smoking, and then these are this is actually the crux of everything, because there are no, as Dr. Sir specified in his lecture, that there is no centralized medication that we have as a prevention as of now. We treat, it is more like a primary prevention than it's more like a secondary prevention rather than a primary prevention in terms of the drugs that comes in, whether it is aspirin or the statins or the GLP-1. We are treating the disease if it is there. And of course, the monitoring, where the lab tests, we for all preeclampsia women, we should
You have to add this
at the at least basic lipid profile, the HbA1c or the fasting blood glucose, and if there has been any severe preeclampsia where the derangement of liver function test or the kidney function test is there, then those tests have to be done after 6 weeks, and preferably an annual health checkup. So I just want to put in about the lipid profile. There is
no, what's the time?
Had asked for that. So in basically in pregnancy,
who told you?
The logical changes in lipid profile, we don't have any set criteria, but postpartum, we definitely should be taking care of the lipid profile. And as Sir had very well explained, depending on the we keep the LDL below 150 and or moderate risks ones below 100 and so on. So this is, I think, the overall. And of course,
absolutely, I think you have covered up everything. But smoking was not very common. Some of us don't even go to bother asking our patients whether they are smoking. But being in Bangalore, dealing with a lot of software engineers, smoking has become very common. In the village side, we have the BD smoking all the time. So we have to make sure that we do talk to them about smoking. Most of us try to avoid that because we feel our women don't smoke. That's no longer true. So we need to follow that up very well. Okay, so basically when you do a long-term follow-up, we have to have 3 layers of protection. The first would be a metabolic control, sugar, weight, lipids. Second one is the vascular protection, BP and endothelial health. Third one would be a pregnancy planning strategy if a future pregnancy is possible. And you have to have a daily or a weekly foundation for these patients. It is a non-negotiable layer. They should have to do that. Number one is diet, that is vascular plus glucose protection. Best pattern would be, either you can have a Mediterranean diet or a DASH hybrid diet, or even our local village diet is better than any of these diets, where you include a lot of ragi or jowar and things like that. Exercise is the most powerful protective tool. The target should be 150 to 300 minutes per week. Sleep, often overlooked, but it is very critical. There should be 7 to 9 hours of sleep for this patient nightly. The cardiovascular monitoring layer includes the blood pressure, home monitoring at least 2 to 4 times per week. Because we have been talking about it, but I wanted all the delegates also to know that how often you do the testing. Targets ideal will be 120 by 80, acceptable will be 130 by 80. Persistently, if it is more than 130 by 80, needs a medicine review. Metabolic monitoring every 3 to 6 months initially. HbA1c for diabetes control, fasting glucose or a lipid profile. Weight plus waist circumference. I think the waist circumference is very important in these patients. So they need a monthly weight checkup, and weight circumference is more important than BMI alone. So make sure we teach our patients this also. Then you have a medical prevention layer, which includes medical plus lifestyle combined. you would include a blood sugar control, a blood pressure prevention, the antihypertensive treatment, the cholesterol protection where you consider statins, and pregnancy specific prevention if future pregnancy is planned. That would of course include the low dose aspirin, early antenatal care, frequent BP and fetal monitoring. And finally, the fourth layer, the risk modification, the risk amplification control, which is very important in this group. Avoid or aggressively manage obesity, sleep apnea, smoking, uncontrolled blood sugar spikes, chronic stress, and poor sleep. So all this has to be looked after. Now, I think the last question to Dr. Tarkeshwari, what are the emerging tools? A lot of new tools are coming up for follow-up of preeclampsia. Dr. Tarkeshwari, what are the emerging tools that are coming in?
So, out of many, I would like to say angiogenic biomarkers is one. The echocardiography with the GLS, what doctor has mentioned earlier. And the third thing is the USCOM, ultrasonic measurement of the cardiac output, which is coming up in a big way and is doable so that you can tailor the antihypertensive therapy for these preeclamptic women. And AA coming in a big way, I think we have other digital things which have to be added.
Absolutely. So there are a lot of new tools coming up. Today, we do not know what exactly is the value, but in future, definitely is going to be holding a higher value. And that would include, like Madam said, anti-angiogenic markers, the interleukin-6, the activin A, the global longitudinal strain on echocardiography, which predicts heart failure, and of course, the USCOM, that is the ultrasonic cardiac output monitoring, which will dictate us what antihypertensive to give. So all these are going to come up in future. The education of people is very important. We have started with Penai, which we already told you before, plus the Suraksha PE is also coming in so that the training of the doctors as well as patients and the community go hand in hand. And finally, the important practice points, women after HTP should be followed carefully at least during the first 5 to 10 years after the delivery. The focus of the follow-up should be on development of hypertension. Women with early onset preeclampsia, recurrent preeclampsia, and preeclampsia and last pregnancy are at increased risk. Multiple pregnancies with HTP, this is a very nice statement, tend to have a lower risk for CVD as compared to singleton pregnancy. Okay. The research agenda, which I hope our society will also take up in future, will be women with HDP should be followed up and registered in a database during at least 10 years after their deliveries. Definitely, it's in my mind, and we would like to do through SMFMI a database. I don't think it's very difficult to do. If all of our members cooperate, we can definitely do it. So the final take-home message, pregnancy is a window into future cardiovascular health. Complications are not isolated events. There are indicators of long-term risk and give us opportunities for prevention. So thank you all very much. And I think my panelists did wonderfully well. A big clap for all of them.
Thank you so much for the opportunity, Dr. Prakash and all panelists.
Thank you, sir. You made it a wonderful panel, sir. There was so much great learning.
Thank you, sir.
Thank you so much.
So taking over from Akshita for the last lap, that is vote of thanks mostly. Akshita had to leave us for an emergency that she had. So I'm Dr. Anu. I'm one of the coordinators for the program SFMI's VLS series. It is my great privilege to deliver the vote of thanks at the end of this enlightening academic session, which we have been now running the third episode, which begins with this first episode. And every episode runs as 3 sessions. This is the first session of the third episode. Thank you all our panelists and our speakers. And we extend our heartfelt gratitude to one and each of you for sharing your valuable time and the insights on cardiovascular disorders and preeclampsia. The knowledge and the perspectives provided today are truly enriched our understanding and inspired us to continue our learning journey with enthusiasm as well as dedication. It was great to see that it has been accepted by many delegates across the country and worldwide who has joined us virtually today, either through the Zoom meeting or watching us through the YouTube channel, which has gone live. We are excited that our SMFMI family is growing across the country. We thank our sir, Prakash Mehta sir, whose vision, constant support and guidance has brought us this far. Dr. Revati, whose hard work has made SMFMI grow leaps and bounds and is being recognized globally. I'd like to thank Dr. Revati for giving us coordinators this opportunity to work for SMFMI and encourage us to be involved in various academic activities. We would like to thank Professor Sarosh Rana, who has guided us and helped us collaborate with ISHP and helped us being visible on international platform. I'd like to thank Professor Anatin staff. Though Madam could not come live with us, her exhaustive description and discussion on long-term cardiovascular outcomes in women with PE and how PE affects the cardiovascular system, the long-term effects of future health and subsequent pregnancy and transitional effect was very inspiring to listen to. I thank Dr. Prabhakar sir for discussing a cardiologist's perspective of future cardiovascular risk in women with PE, antihypertensive therapy, the statin therapy, aspirin use, the myths and the way forward, the contraceptive use, and when to trigger referral by the gynecologist towards a physician or a cardiologist. It was indeed very exhaustive talk. I thank all the panelists, Dr. Tarakeshwari ma'am, Dr. Pankaj Rani sir, Dr. Shashikala ma'am, and Dr. Vandana Goyal ma'am for their seamless discussion and sharing their extensive experience with cardiovascular diseases. As we bring this wonderful event to a close, it's my honor and privilege to extend heartfelt note of thanks to the amazing team who has made today possible. Shield Connect, our knowledge partner, and their members, Mr. H.R. Balaji, the Vice President of Shield Healthcare, who needs a special mention because he has extended his academic grant for the VLSP series for the third time in a row. We thank Ms. Sahiti Priya, who has been running the show seamlessly from Shield Healthcare. We thank all the EC members of SMFMI for their hard work, dedication, and passion. And a special mention goes to the behind-scenes staff of SFMI office staff, Mr. Raj Gopal, who ensures every detail is perfect, have worked tirelessly, meticulously, and ensured that everything runs smoothly. Your efforts truly reflect the commitment you have to our society and to making every event perfect. I'd like to thank also Dr. Meghna Srinath, who's not in the country, but works as a research associate at Mount Sinai Hospital, New York, and has been a vital part of SMFMI with her virtual contribution to the society. Last, but never the least, I extend my gratitude to all the delegates present here and also watching us on YouTube for their active participation and attention. Let us carry forward the knowledge we have gained today and make the best use of it in managing our patients and saving life. And coincidentally, today being Mother's Day, the happy Mother's Day, let's also put together this education that we have learned today and the insights that we have had today towards a better motherhood for all our future patients and the patients of the past. Thank you so much.
Thank you for the wonderful opportunity. Happy Mother's Day.
Today is
Happy Mother's Day to all the mothers and all our patient mothers also. And I think because it's a Mother's Day, we need to make a further commitment that we will not allow our preeclampsia to go unmonitored after delivery.
It's also part of the World Preeclampsia Awareness Month.
Yes. And again, I take this opportunity to invite all those who are watching this program that on May 22nd, we have our Suraksha program, which is mainly meant for the how to bring about the awareness of preeclampsia in the community. So please do join us. I know it's a working day, but then May 22nd is the preeclampsia day. So we had to hold the program on that day. Please do join us from wherever you are so that we all join hands together and improve our mother's health. So thank you all very much and hope to see you all again. Have a great Sunday and a good rest after